All right, so it is today, which is Tuesday, right? Yeah, today's Tuesday, June 22nd, 2021, and we are going to talk about Therex today, specifically dealing with soft tissue injuries, um, nerve injuries, and then also upper extremity injuries kind of stuff. Just a reminder that, again, I said that tomorrow I will be in lab from about 8 o'clock till 11-ish, 11:30-ish. I'm not sure what time we'll be done tomorrow. I'll be definitely out by 11:30 because I have to be back on a Zoom call at 12. So I have to get out of there at 11:30. And so if you do want to sign out a goniometer, if you want to return something that you have signed out, I'll be there for you to either come in and borrow or return stuff. Also, if you're interested in the textbook that I use as kind of a reference, the Fundamental Orthopedic Management book, we do have a couple copies up front. If you're froggy and want to sign it out, I am not telling you to sign it out. I start tomorrow at 8. Yeah, so they changed the start times for the morning group. The morning group now starts at 8 a.m. instead of 8:30. Yay. Probably be there by like 7:45 if you're somebody like me that gets up early, but if not, Dr. Johnson will definitely be there by 7:45. But yeah, so like 8 o'clock to 11:30-ish. I have to fix Dr. Vreskin's computer tomorrow too, so that may keep me there longer. She has wonderful, I don't know if you've ever seen this, but battery bloat on a laptop where the actual battery expands to the point that it literally is going to explode. I have to replace her battery for her. I feel bad for her. Anyway, so today we are going to talk about nerves and soft tissue injuries. So we're going to use some terms that we've already kind of talked about, right? So sprain and strain, we already talked about, right? Strain, I want you to think tendon, which means muscle, and a sprain is ligament. But like I said, they may be used interchangeably. So if your clinic calls both of them sprains or both of them strains, they're not technically wrong, but they're wrong. When it comes to your boards, if they are discussing a sprain, they are talking about a ligament. If they are talking about a strain, they are talking about a muscle. So just be aware of that for your boards. Then we have these two terms, subluxation and dislocation, right? And a lot of times these get used pretty interchangeably too, but they're different. So subluxation is a partial dislocation, whereas dislocation is, well, a dislocation. It's actually where the full joint is out of socket. So the shoulder is a great example of it because the shoulder very frequently subluxes in older adults. And what it'll do is the humeral head will drift inferiorly in the socket. So it loses superior contact with the socket. And it'll just kind of hang on that bottom part of the glenoid fossa. That is when it subluxes. If it fully dislocates, that means that the head of the humerus is completely out of the socket and somewhere else. Just saw there was a MMA fight. I want to say it was in either Croatia or Czechoslovakia or one of those. I can't remember where the guy had a dislocated elbow. And when it dislocated, you could see the olecranon fossa on the x-ray. I wanted to get a picture of it. It was just on one of the sports channels. The olecranon fossa was up here about mid-tricep, or the olecranon was up here about mid-tricep. It had dislocated that much, so basically went posterior and slid up the arm. That would be a dislocation, right? A subluxation of the elbow would be is if that elbow or that olecranon shifts laterally, inferiorly, or superiorly in that olecranon fossa. When we talk about a rupture or a tear, a rupture is typically thought of as a part where that literally that tendon just kind of explodes or that ligament kind of explodes. Usually when you think of ruptures, you're thinking of an uneven tear. So like if you took a piece of paper and you ripped it, that piece of paper can kind of rip in a nice even line. That is kind of a tear. A rupture would be one where it kind of tears off in a jagged piece that things don't mate up very easily. That's more of a true rupture. Ruptures often are thought of more in the lines of where bone might rip off with that tendon or something like that, where you get an avulsion. And then tendinopathies and tendinous lesions, obviously at that point, are problems with the tendinous portion of the muscle. So when you get down to either the origin tendon or the insertion tendon. And there are a lot of tendinopathies that can happen out there, right? There's tenosynovitis, there's tendonitis, there's all of those that are out there. And those just two. I mean, there are diseases that specifically attack the tendons and the Golgi tendon organs. So that is a pathology with the tendon. A synovitis is inflammation of a synovial sac or a synovial joint portion, right? So the part of the lubrication part of the joint. When you have a problem with both, so when you have a problem with both the tendon and the synovial joint, that's when you see something like tenosynovitis or tenosynovitis. Does anyone know what muscle is really common to get tenosynovitis in? Okay, the Achilles, good. Not really the quads so much, but I guess, I mean, theoretically you could, right? Especially with osteoslaughters.
Is it the pollic brevis and longus?
There we go, right? Yeah, the pollicis brevis and longus, good. And then the other one is actually the bicep. The bicep gets bicipital tenosynovitis very frequently, specifically of the long head. So when it's just sliding in those grooves, it just gets kind of inflamed up and it causes problems. And also when that happens, sometimes that causes then the superior portion of the shoulder to swell up and you can end up with other problems as well. So tenosynovitis or tenosynovitis is when you kind of combine both of those. And the Achilles is another one, right? Pollicis longus is one that we get as a gamer, right? That's where you get that fun. Does anyone remember what that was called, where I told you about the test like this? Starts with the D.
Dequavers or something like that?
Dequervains. Good guess. That's right. Yeah. See? You did learn something at least, right? Hemarthrosis. What does that literally mean if you broke that down? Hemarthrosis.
Well, hema is blood, arthrosis is joint, and cis is condition of?
Yeah.
No.
Yep, you're right. Right? So it's a condition of a bloody joint, like Anthony said there. Right? So that's where you get a hematoma or a bruise that actually occurs in the joint. And that can be problematic, right? Because that joint, like if you have a hemarthrosis of your finger and it's of like this, the proximal interphalangeal joint, there's not a lot of space in that joint, right? So if I suddenly fill that space with blood, that's going to limit my motion, right? And I can no longer phone home. So hemarthrosis is where you get blood in the joint, obviously in that kind of extracapsular area where it's not supposed to be there. It's not contained in a blood vessel. A hematoma is just nothing more than a bruise, right? We can get hematomas pretty much everywhere. We can also get hematomas of the bone, right? Has anyone ever gotten a bone bruise before? Or a pointer? Where you just get that bang on that bone so bad that it just kind of swells up on that outer periosteum region. It's really painful. Bone bruises are really uncomfortable. Snowboarding and tailbone, exactly, yeah. I had that the first time I went roller skating. I landed on my butt for like a week. I couldn't sit. I didn't break my tailbone. Man, I had a nasty bone bruise on my butt. That's different than a hemangioma. So heman, again, dealing with blood. Gioma, right? So hemana, blood, angia, blood vessel, right? And oma meaning what?
Tumor.
Tumor, yeah, right? So this is a blood vessel tumor. And what the hemangioma is, and they happen to the spine quite frequently. So if here's my vertebral body, right? out on the outsides here, I have blood vessels that are going in and kind of providing some blood to that spine, that actual the body of the spine, right? We know that the outside of the bones usually are kind of the most vascular areas. That's where the blood is going to feed and bathe the bone in fluid and stuff like that. What happens with the hemangioma is all of a sudden I start getting blood vessel growth in the bone. I can also get abnormal blood vessel growth in a muscle as well. I can get a hemangioma of, say, the triceps. And that's abnormal blood vessel growth in the tissue. If I have that in either a bone or a muscle, is that going to affect structural integrity?
Yes.
Yeah. Right? Think about it. This is supposed to be all solid bone. Now I've got some squishy blood vessels here. And so especially in the spine, it's going to definitely affect structural integrity. And then if I have it in a muscle, right, it's going to be an area that may be up pretty wrapped for rupture, right? So that's a big thing. A ganglion is nothing more than a ballooning. Typically, you think of something like a ganglion cyst, right? A ganglion cyst is where you get a ballooning of the joint capsule and it kind of gets hard. So it may happen in tendon. You may also get a dorsal root ganglion, right? You've heard of that before, right? It's the balloon back at the dorsal root. It can also happen in nerves. So you could get a ganglion cyst of your median nerve, right? And those are, I've seen patients that have them where like their whole middle part of their wrist just swells up like a huge lump and they have to go in and remove those. Bursitis, exactly like it sounds, right? Inflammation of the bursa. Contusion is hemangioma, right? And then the other thing that we face a lot is overuse or cumulative trauma disorders, right here, right? Where repetitive strain injuries. I'm noticing lately, and I don't know about you guys, but I'm really noticing lately, I'm getting repetitive strain injuries of my eyes. Because I'm spending so much time, contusion is a bruise. It's another term for a hematoma, which is another term for a bruise. Yep. I've noticed that my eyes lately aren't as focused as they normally are, especially when I'm not sitting at my computer. Like my eyes are just tired more frequently because I'm sitting more at a computer. I'm not up teaching you guys in front of the room where I'm moving around and doing stuff like that. So I think this pandemic has definitely affected my eye function, where, you know, I'm getting a little bit of a repetitive strain injury of the eyes. You can get it from typing. You can get it from gaming. You can get it from lifting, especially at the end of the night. Yeah, right? And we all have that a little bit where that as we get older, Riley, we get what's called presbyopia, which means older eyes. And as the night, your vision usually kind of declines as the night goes on. And that's why a lot of older folk will choose not to drive at night because they literally can't see, right? Because I had to in a second, Joe. Let me finish my thought process here. I was trying to question. So, yeah, that's a good question, Chris. I was actually going to go there next. So at night, right, we know that the cones are in charge of our colors. They usually don't age as effective or as bad as our rods do, the ones that handle our blacks and whites. And so I think that I think like Chris said, I think probably, you know, we're going to see that there may be a decrease in vision over the next few years. Or the other thing it might lead to, Kirsty, is we might actually have more people going to get vision correction that probably needed it in the first place, but then have been putting it off, right? This is going to be one of those, is it that there are more people going to the eye doctor because they have more problems, or is it because they actually realize they have a problem now? You know, I have a friend that I know right now that needs glasses. I'm sure probably all of you have that one friend. And he still, to this day, refuses, like, I don't need glasses. My vision's just fine. Go get glasses, dude. Go get contacts or something. So Joe asked, is a hematoma or hemangioma, which is more likely to cause a bone tumor? Well, So they don't necessarily, they can, that's glasses. Yeah, exactly. I'm at least not to the point where I lose my glasses yet, because I have to wear them to see, thank God. Eventually probably be my dementia as I'm walking around with my glasses on my forehead looking for them. So Joe asked about hemangioma or hematoma, which is more likely to cause bone tumor. Well, so that's a little bit of a complicated question there, Joe, because in reality, a true bone tumor, so a true malignancy of bone, isn't necessarily caused by actual blood in the bone itself. It's usually caused by metastasizing of the bone itself, usually of the actual soft bone, right? So where the soft bone just reproduces way too much, because that's what creates that creates most of our stem cells and stuff like that. And so that keeps differentiating. We get too much of a tumor there. But I have seen people that have developed worsening tumors with hemangiomas, right? And that makes sense if you think about it, because if you get kind of blood vessel growth into the area and you have a propensity, right? A propensity for weird growth. You already have kind of a propensity for getting a tumor. And now you feed it more blood. That kind of causes a cascade effect, right? Because we know that we need more blood in order to grow. And so he said, I had a massive statue, crush my leg and get an osteoblastoma. Yeah. And that can happen. I'm sorry that it happened to you. You would think you could dodge statues a little bit better, but I don't know what happened there. I'm just kidding. Did you pull down a statue of General Lee? No, just kidding. I'm just joking. Yeah, so I could see how you could get a little bit of an osteoma from that, but yeah, it's just, I think at that point you're looking at more that you have an increased blood flow in that area, so it would likely help it grow along more than anything. A hematoma is not really going to cause a blood tumor. I mean, you could get a tumor from a hematoma, but it's going to be more of like an abnormal soft tissue tumor than it would be a bone tumor. Because again, a hematoma usually is blood in kind of the perispace or the area around the soft tissue. Same thing with like a contusion soft tissue type base. So we have all these fun terms over here, tendonitis, tendinosis. I just put them in there in case you were interested in them. The only one that always kind of confused me, and usually when I saw this, like the first time I saw this term really confused me. I hope you guys can see why that would be a confusing term. I'm like, wait, what? What are they asking me? Tenovaginitis is a thickened sheath of a tendon. That was not what I was understanding it to be there. I was really confused. But yeah, we'll just move on. So what can cause or what can happen with trauma or pathology of our soft tissue? Well, obviously dysfunction and joint dysfunction are two main things, right? Dysfunction meaning just generalized bodily dysfunction, and then joint dysfunction specifically of the joint. When we end up with a joint dysfunction or dysfunction in general, we start contracting. That is a side effect of not moving, right? When we start contracting, we can also develop adhesions. And so stuff starts sticking together. And then a lot of times, because we start developing pain, right? And you've all had this before, where maybe you sprained an ankle or sprained a wrist. You do what's called reflexive muscle guarding, right? Like right now, I don't like to extend my wrist right now because when I extend my wrist, it kind of causes my tinglies to get worse, which is the only thing I get in my hand. So I guess I should be happy that I get the tinglies. Just not look a gift horse in the mouth. I've got tinglies right now. But so in order to prevent that, I kind of tighten up and keep my hand from going into extension quite frequently. An intrinsic muscle spasm is something that will happen at the muscular level, right? It's going to work off of kind of that Golgi tendon apparatus and say that, hey, you know what? I'm going to cause the muscle to kind of spasm and twitch in order to prevent any further damaging of it. And whether the muscle weakness comes before the contracture, or the contracture comes before the muscle weakness, eventually the muscles will weaken and waste. Is this in order? Absolutely not, John. That's what I was going to get at right now is that, so in this case here, right, we're talking about, this is just talking about things that can happen. A lot of times when we end up with a contracture, we get muscle wasting. But we could get muscle wasting, which leads to a contracture. So it's not specific in any order here, but a lot of times you're not just going to have, like, I'm not just going to have a joint dysfunction. I'm going to have a joint dysfunction because of adhesions, which leads me to guarding, which leads me to muscle wasting, right? And then ultimately, the more and more I kind of protect those areas, it can then lead down here to these two big ones, right? The myofascial compartment syndrome or the myofascial complex regional pain syndrome, which is kind of the ultimate or the penultimate bad thing that happens to soft tissue. It really is. It's truly like that. That's the ultimate, oh my God, you haven't taken care of whatever the problem is. So now my body is literally going to shear off, or in the case of compartment syndrome, shunt off that area. Or in the case of myofascial complex regional pain syndrome, I'm going to trigger so much ridiculous pain that you finally pay attention to me. So a lot of times that's just kind of the body's final way of saying, hey, look, idiot, you didn't pay attention. So when we have sprains and strains, the first degree is kind of the mildest, right? So a first degree sprain is also tends to be, honestly, for me at least, a first degree sprain usually is the most painful at the very beginning. Because a first degree sprain is almost like a paper cut. It's a really, really tiny kind of sprain. There'll be pain at the injury site or within 24 hours. So if you just twist your ankle, right, and you get a first degree sprain, it's going to swell up, it's going to get red, it's going to get warm. And the main thing is it's going to be really tender and painful when you stress the tissue. So if you get an inversion sprain, if you move that ankle back into inversion, it's going to cause pain and tenderness because the body is saying, I don't like that, right? Most of my patients that I've encountered, when they get a sprain or strain, it's either a grade 1 or a grade 2, and those are kind of the most painful ones patients get. A grade 2 is a little bit more severe, and again, there's not a specific percentage. So it's not like saying, well, a grade 1 is 1 millimeter and a grade 2 is 5 millimeters or something like that. What they'll say is that a grade 1 sprain or strain is a mild, either over torsioning or a little itsy bitsy tear. The grade 2, I get a little bit more of a tear going on, right? So get some pretty mild fiber tears. And you do get some increased mobility there, mainly because that ligament has now got some part of it that's damaged. Most of the time with a second degree sprain, it stops your activity, right? This is the one where you step off a curb and now, and now you can't walk the rest of the strip. You may have to get a ride home. That would be kind of a second degree sprain. If you stress or palpate it again, it increases the pain. It definitely makes it worse. And there is some hypermobility in the joint. So again, if we're looking at the ankle and you're kind of moving it around, there's a little bit more inversion or eversion, whichever way you sprain it, than you normally would have. Typically, a grade 3 strain or sprain is the one that most people don't even realize they do. Because when it happens, it's either a near complete or complete tear. There's extreme pain when it happens. So when you do it, it's like, ow, son of a, oh my God. And then within a few minutes, the pain kind of stops. Why would the pain stop in that kind of a sprain? Okay, here's shock. Might be a theory. Yeah, nerve damage. Yeah, right? So if I rip off and get a Popeye tear of my bicep, I'm sorry, Popeye tear's down here. What I forget those ones called. But my bicep rips off my distal portion and starts rolling up. It's going to hurt like hell when it rips off. But as soon as it rips off, the nerve's damaged. And at that point, I no longer feel anything. Headset decided to turn off. I don't know why. So at that point that it kind of ripped off like that, it's gone. The nerve no longer has any sensation there. You may get some residual sensation pain like in the sorry, I had to move stuff around here real quick, in the actual generalized area of it. But for the most part, and for the most everything else, you really don't get any new pain. It's not really what I want to say. There's no intense super pain after a grade 3 sprain or strain. And those are kind of the ones, like I said, most of the people kind of want, because if you're going to get one, well, you might as well be the one that doesn't hurt, right? But the downside to that is, if it doesn't hurt, what does that mean? That means it's bad, right? Yeah, exactly, right? And how long does pain last? Well, when I tore my rotator cuff, it was about 10 minutes. I was shoveling snow, so I went out and, so snow is this white stuff that falls from the sky and coats the ground, and it's really cold, just in case none of you knew what snow was. But in back where I'm from in Pennsylvania, it snows a lot. And we had this plow driver that came through for the county, that my road, or my driveway, was right at the end of a road that came in. And so he would plow all the snow up into my driveway. Yeah, S-N-O-W, funny, Anthony. And so I went out and I would shovel my driveway, and I'd look out there an hour later and I'd have this big wall of ice back in my driveway. And so then I'd go back out there and I'd shovel my driveway an hour later. And so the last time he did that, I was just so angry, and I just went out there and I was putting it up in my yard and taking it away. The last time when I was just angry and I started flinging it back out in the road and I wasn't thinking, and I grabbed one shovelful and I flung it. And when I flung it, I heard in my shoulder a little bit of like a crackle. And then I had this really intense pain for like 10 minutes, and then the pain stopped. And this is before physical therapy. I'm like, oh, well, I mustn't have done anything, right? You're thinking, yeah, and we're going to talk about that in a minute. There is a healing time frame. Obviously, when you're looking at the overall healing hierarchy, right? Because if you had to figure out and go, well, which one's going to take longer to heal? Obviously, those grade 3s are definitely going to take longer to heal than anything else, right? Because when you look at it going, oh yeah, that kind of makes sense, because those grade 3s are a complete tear. Oh no, did I just lose you guys? Where did that go? Chat. There we go. So that's kind of a big thing there is, if you have a grade 3, it's not a good thing, is what I'm saying. But for the most part, there is a overall kind of generalization. It's 8 to 12 weeks is a good kind of grade 2 thing. 6 to 8 weeks maybe for a grade 1, or maybe less than 6 weeks if you're kind of a healthy person. But when it comes along, those, again, it's going to depend on person, how much activity that person does, right? If they don't do anything, it's going to take them forever to heal. What their health is like, right? Especially if you got somebody that's got some really unhealthy habits, and we don't have any of those in America, right? And John asks, so stretching the only real preventative measure? It is stretching and then strengthening the associated musculatures of the joints, right? So like in the case of the ankle, making sure your peroneals, your tibialis anterior, your tibialis posterior, your gastrocs, and all those muscles are good and strong, because that'll help stabilize the joint from a strength standpoint. So that's not only relying on the actual ligaments themselves for stability of the joint. But yeah, stretching is pretty much the only real preventative measures, basically having functional mobility, right? When things are really super tight, you're more at risk for it. So we're going to look at the muscle now really quick. So we're going to look at the macro and microstructure of the muscle. We're going to go back to anatomy kind of 1 when we were talking, actually it's anatomy 1 late semester. Right, so when we talk about muscles and tendons, there are about 600 skeletal muscles and tendons in the human body, right? This includes muscle fibers, connective tissue, blood supply, and all those innervating nerves that go to it. When we have a contraction of that muscle, the contraction of the muscle is going to move typically a joint through the motion, depending upon how much tension and force is pulled. There is always a musculocutaneous or musculotendinous junction. That's where the muscle stops. So those muscle fibers end, and then the tendon starts. That can be a weak point on some people's muscles. And if it's, especially if they've got overly strengthened muscles, right? So think like bodybuilders. It's really common for bodybuilders to get muscle tears, not because they're super strong. That is part of it. But the other part is their muscles build up so much hypertrophy, so much muscle, that the tendon can no longer hold on to the amount of muscle they have there. And that leads to tears. So in the actual structure of the muscle, right, we have a couple different layers. We have the epimysium, the perimysium, and the endomysium, right, which is the outside, the kind of that surrounds the group of fibers and then surrounds each individual fiber. So we have little fascial layers all the way around different parts. Those all kind of then get divided up into the muscle fibers, which then get divided up into the myofibrils, right? And down to the myofilaments. And then you have your sarcomeres, right? That are kind of those smallest components that have the actin and myosin. Do you remember all that kind of back from anatomy? The triggering some memories?
Yes.
Good. It's triggering some bad memories? Nightmares, right? So the big question then becomes, Mr. Uncle gives us a lot of crap. What do I have to know for my boards, right? That's ultimate. And then what do I have to know for real world? Well, the good news here is if you're working in a sports-oriented, sports orthopedic, specifically dealing with athletes, you really are going to have to know these structures and functions of muscles. That's just a given because you're dealing with people that obviously have more muscle to their body. If you're dealing with, Sue, the 65-year-old person who spent all of her life working at Toys R Us or something like that, you don't have to worry about this as much. For the boards, you definitely have to understand kind of how the muscles break down. The main thing you have to remember, and the main things I've seen on your boards, is just remembering that when you get down to these muscle fibers, they're divided into the myofibrils. So when it talks about a myofibril, it's talking about those muscle fibers that you get down to the base level. So it might ask, the muscle fiber term is X, and that's myofibril. They typically don't go down here when they talk about the sarcomeres and your actin and myosin. It usually doesn't get that far in depth on your boards. I mean, is it possible there could be a question on that? I guess, sure. It's also possible there could be a question about the JFK shooting. Not likely, but it's possible. I mean, they could be asking about like JFK's neck muscles or something like that. I have no idea. So it's not likely you're going to get a sarcomere, sarcomere, actin, and myosin question, but you do have to remember that the muscle fibers themselves, if you see something called when it talks about myofibrils, I think there's a chance, right? When they talk about myofibrils, you need to remember that at that point, they're really talking about the individual fibers of the muscle themselves. Do the myofibrils, for the most part, run in parallel with each other? So if you're looking at the bicep, would most of the myofibrils run parallel with each other? Yeah, absolutely, right? That's kind of the way a muscle is designed. That's to allow for that pull. If they kind of ran crosshatch all over the place, that would affect your pull, right? So if you get a really big tear, and instead of it growing back as nice, inline myofibrils, and you get scar tissue there, that's going to affect the pull of your muscle, and your muscle may not be as effective. That's why this is kind of important to kind of understand when you get down there. There's definitely gonna be no questions on the Z disc and the Z line, so don't worry about those. Heterotopic or ectopic ossification is an interesting term. So this is another kind of soft tissue disorder where you get bone growing where there shouldn't be any bone, right? So it can grow in the muscle, it can grow in the skin, it can grow in the lungs, it can grow in the heart. Any area that you have a part that's not supposed to have a bone there, bone can theoretically grow. It's called heterotopic or ectopic, meaning not supposed to be there. Ossification, growth of bone. So this is where your body sends out satellite or different undifferentiated cells to repair a certain area. So maybe you got a tear in a muscle, and it sent those undifferentiated cells that would lay down the collagen and the all the different stuff, the peptin and stuff like that, to lay down and reheal the muscle. But for whatever reason, instead of converting to muscle, those undifferentiated cells flip a switch in them and they grow into bone. That can be problematic, right? It can be following severe injury to muscle, like again, a tear. There is also a term called Myositis Ossificans, which may have been part of what might have happened to Joe with his statue falling on him. Because technically Myositis Ossificans is where you get an abnormal bone growth in soft tissue that theoretically could be considered a bone tumor. So myositis, inflammation of the muscle, ossificans, where instead of growing back as muscle, it turns to bone. Cartilage itself will gradually calcify over time as, the blood vessels maybe don't neovascularize, don't regrow back in that area, or just over time. That's kind of what happens to a lot of our articular discs in our spine, our medial menisci, lateral menisci, not so much, but a lot of those areas where we have that cartilage that is really kind of used for impact absorption. As it just gets beat up and beat up and beat up and kind of dries out, it can basically shear over into bone. And so that's why we may end up having to get a knee replacement, or may have to get where they go in and fuse a joint in the spine. The interesting one, this is kind of an interesting one to me at least, that I thought was kind of cool. There's one called the fibella. And the fibella is a really tiny sesamoid bone found in some mammals embedded in the tendon of the lateral head of the gastroc. Specifically, this fibella is found in cats. Why do you think a bone would need to grow in a cat's gastroc?
Like jumping purposes?
Right, pouncing and jumping, exactly, right? Because what do we know? So that's going to be a sesamoid bone, right? It's going to be a floating bone. And so if it floats in there, it's going to create a pulley, right? It's going to increase the lever arm. And so by increasing that lever arm, you can do it, right? So specifically, and I see if I find, I think I still have an x-ray of my buddy. My buddy has a Bengal cat. And I don't know if you've ever seen a Bengal cat before, but like literally I've watched his Bengal cat and he has one of those big old, like the Zero Cool refrigerators are like 10 feet tall. His cat can literally jump from the base of that to the top like it's nothing. Just like poop, and he sits up on the refrigerator and stares down at you. How did you get up there? Don't look at me, dude. You jump up here once. Like panthers and leopards that jump up in and out of trees all the time. They need that advantage for jumping. Well, this can happen to humans as well, right? They get an anatomical variation of this. It's present about 40% of humans, or 39% if you want to be technical about it. And it can be just completely asymptomatic. It doesn't cause any pain, doesn't cause any problem. It's just there. And oftentimes they'll find it after you go in for like some other problem with the knee. They'll do an x-ray of your leg or of your knee, and the doctor will go, hey, look. Theoretically, Riley, and I'd be curious about this, because I'd be really curious if we looked at people that are like high jumpers, if they actually develop this. Because I'm willing to bet like them and pole vaulters and people that do a lot, or long jumpers even, right? I'd be willing to bet if we looked at their gastroc, they probably might develop a fibella. I don't know for sure. It's just kind of I'm musing, if you will. So Joe asked a good question. Could it create a spring block end field? It could. Are you talking about more like a bony block end field, or are you talking that it would create kind of a bounce back? Which are you talking about? Yeah, just different. Yeah, right. I mean, theoretically, when it happens, literally, Joe, the bones may be that big, so it's not that big. So if you look up here in that picture up top here, there's how big it is. So it's not very large at all. It would be an interesting biomechanics study, right? I would imagine that it could cause a problem with knee flexion. I would imagine it would cause a weird feeling with knee flexion, that you might get a hitching when you go through knee flexion. It may not stop the knee flexion, but you may get a point where it kind of settles into place and you might get like a little bit of a hitch going through it. I don't know. I've never encountered somebody that really had that I knew of, but it would definitely be an interesting study, right? To see if the people that with the fibella jump higher than people that don't. Here's one that developed in the lateral hip, which I thought was kind of interesting. It can lead to posterior lateral knee pain. So it is possible that little fibella can lead to pain for certain people, where like things get kind of soft and where they got chondromalacia fibellae, or kind of osteoarthritic changes in the actual knee joint itself. And I tried to look it up to see what the doctors do for this. You know, well, do the doctors go in and do surgery on it? And there was one study done, I think it was 1939, I was looking at it, that looked at the efficacy of going in and doing surgery on it. And interestingly enough, they found that if they go in and they remove the fibella, it actually damages the tissue more than if they just leave it in, right? Because it's such a small bone anyway. And if you have to go in and cut on that muscle, obviously you cause surgery, patients just don't heal as well. But again, that was 1939. I haven't seen anything since. And maybe it's just because now we just say, okay, well, we'll treat it conservatively. There are some things there was a couple out there that showed that doing something like a typical bone softening program where we do ultrasound with acetic acid or something like that can make some difference in it, or doing ultrasound with anti-inflammatory drugs can help with it. But for the most part, it looks like we just go, you've got a weird leg, dude, and just teach you how to deal with it. They can occur anywhere in the body. So if they occur somewhere else, so fibella is just in the back of the calf there. That's just what that name of that little bone is. But the actual heterotopic ossification can occur anywhere. Yeah, so see, this is the trick, right? I mean, to ask that, and that means somebody else had it. So this is a good thing, right? We've learned. I had one where they got a heterotopic ossification in the middle of the biceps. He was a bodybuilder, you know, and I would say actually he was a power lifter. He wasn't a bodybuilder. Just got to kind of separate those two. And he was doing preacher curls over the bench and lifted way too heavy on one and tore part of his mid bicep. And then, you know, came to us for therapy. Was going to therapy, was told, guess what the doctor said for him not to do for 8 weeks? Don't do what? Don't lift, right? Stop lifting for 8 weeks. What do you think Meathead did? Like within a week of us getting him feeling a little bit better, yeah, he rested. Exactly. That's exactly what he did, John. He went right back to lifting. We got him the inflammation calmed down. And he walked right back into the gym, exactly, and started lifting again. And about 6 weeks later, he wasn't getting any better. Like there was no appreciable improvement in muscle strength. And he's like, man, it feels weird now when I contract up. And when he contracted up, you could just see this little bump appear in his bicep. And so we sent him for an x-ray, and sure enough, that tear had calcified. And he had a little bit of a bone in there. And he's like, well, does that help me lift better? No, dude, that's actually going to make it worse. Right? And so I don't remember what his surgeon did. I want to say his surgeon actually went in and kind of cut it out. The downside to that, again, is any surgery or insult we give the muscle makes that muscle weaker. So I never saw him again. I think he blamed us for getting it, but in reality, I mean, it was him. So heterotopic ossification is bone growth. Now, yeah, so that was what I was going to say. Now, this can also occur in patients who are bedridden. I have actually seen some bone growth occur in the glutes. You know, from constant pressure on it, the body says, well, we're not using these muscles. We're laying on them. Let's layer a layer of calcification over them to protect the tissue underneath it. And so we've gotten some calcifications of the glutes. I've seen calcification of the Achilles tendon before. You want to talk about limiting some motion? That's definitely going to limit your motion if that Achilles tendon gets calcified over, right? And then again, I kind of consulted the hand therapist that I know about this because I have some stuff coming up on hand therapy, and I said, "Do you have any weird stories about calcification of the hands?" And she's like, "Yeah, I've got a patient right now that had a stroke. And after she had a stroke, she lost use of her left arm. So she had it in a sling. And her interosseous bones, or interosseous muscle, all calcified. So her main part of her hand here is now kind of a solid brick. So she doesn't have any abduction of the fingers whatsoever. She can still flex her fingers for the most part. I mean, limited, right? We can do joint moves, but again, it's not going to break the bone up, right? That's the thing, is surgery may be the only option. Or like I said, if it's something where no T1 movement, what are you saying there, Brooke? So maybe I'm confused.
The manual muscle testing, that's T1, right? Abduction of the...
Yep, it is. Good. Okay. Yep, exactly. Good. I was trying to figure, I'm like, wait, did I miss something? I was like, I thought we were talking about surgery for a second. I'm like, wait.
No worries.
That's okay. Yes, T1 manual muscle testing. You got it. So in the case of, I've seen calcification of the plantar surface, or the plantar fasciita, or plantar fascia in that case, John. So when we have that, we can go down there and we can hit that with some acetic acid and do ultrasound with acetic acid on it, and that will soften it up. And if we catch it early enough and we soften it enough, that hard tissue will kind of get reabsorbed back into the bloodstream, and the soft tissue will remain if we can catch it early enough. If, like this lady here, who didn't come to therapy for 3 years, and her hand is now, this whole part of her hand is all of a brick, there's really not even surgery that's going to help that, right? Because what are they going to go in and cut out the interossei? No. And so what the surgeon said is, try to teach her functional movements with the lumbricals to allow her to do just basic stuff. And she's right-handed anyway, so that's a bonus at least, right? For me, you know, like my luck, I'm left-handed, and that's the side that's affected by me. It's to me, though, the one thing about this is it's just an interesting side effect, right? You would never think that like weird bone growth would happen. I looked, I was trying to see if there's any, like, I was really curious. I'm like, I wonder if there's any incidences of bone growth occurring in the brain. And I couldn't find any research on that. So I guess it doesn't happen inside the brain tissue itself. There was one that talked about some weird bone growth in the spinal cord, though, where it actually a bone grew on the spinal cord. And at that point, I don't know what you do. Like it was just talking about a case study, and I don't know what you do at that point. So when we have a soft tissue injury, whether it's, you know, a tear, a rupture, an avulsion, whatever it may be, obviously we're going to break it down into those 3 stages again, right? The protection phase, right? The controlled motion, and then the return to function or the chronic inflammation. So in that protection phase, we're going to get that inflammatory reaction that goes on. In that time, we're going to give them patient education, protect the tissue like we always do. Again, this looks like exactly like everything we've talked about this semester. We are going to try to prevent the problems because of immobility, because we're not going to let them move it, but we also don't want them to get contractures because they're not moving it. So we're going to do passive motion, some soft tissue work, right? We may do some e-stim and ultrasound with specific interventions and dosages. Low dosage or those grade 1 mobilizations. And in the muscle setting, or those isometric exercises. And massage can be really big for patients that have tendon repairs for 2 reasons. Number one, massage triggers that gait control theory, right? That makes it feel a little bit better. The other thing is massage also helps move some of that swelling out, right? If you're not moving the ankle, the swelling can just sit there. So if you can get somebody to get massage a little bit and help push some of that fluid out of the ankle, that can really help pain. With resistive activity, are we going to do a ton of resistive activity here in the acute phase? Where might we do resistive activity though? So we may not want to do our resistive. So if I, like my wrist right now is inflamed, I don't want to do resistive activity of the wrist. But could I do resistive activity of the muscles that are outside of the wrist? Yeah, right. I could do some of my, I don't want to do a lot of flexion extension stuff, right? But I could do some bicep work, right? Maybe some hammer curls, stuff like that, that work the muscles kind of surrounding it, but not directly in it. That way I allow that area to kind of calm down. And again, what I've got here is I've got some compression on, right? That's the main idea there. So protection, rest, right? Price, protection, rest, ice, compression, elevation. And if you notice, one of the things that I don't know if you've noticed, I've been doing it kind of out of habit. I've kind of rested my elbow down here and kind of had that hand up because it keeps swelling down. Isometric exercises are going to be the big ones. And again, those are the muscles. So in the case of my wrist here that I've got injuries, could I do isometric exercises in my brace here? Right? I could. Look, I can use that brace to do isometric exercise. Even though I'm getting a little bit of motion, I'm not getting a ton. And then I can sit there and go, okay, I'm going to work isometric wrist flexion. All right, good. 5, 4, 3, 2, 1. Now let's work isometric wrist extension. 4, 3, 2, 1. Am I going to gain a ton of strength doing isometrics?
No.
No, right? But what is it going to do? It's going to keep me from what? Yeah, keep me from atrophying, keep me from losing it. Yeah, yep, good. Right, so that's kind of the important part of doing that, is that the isometrics themselves will kind of keep me from losing that muscle strength when it comes to that. I'm just using my wrist as an example again because, well, it's sore and achy, and I actually kind of like it. I like having pain in this hand. It's something. And then we're going to give them a home exercise program, right? And again, understand when you give a patient, and the PTU prescribes a home exercise program for the patient, the simpler the program, the more likely that patient is to follow the home exercise program, right? So let's say that Anthony is my patient. If I give him 50 exercises to go home with and do 50 exercises at home, is he likely to do all 50 of those exercises?
No.
Heck no, right? He's going to be like, what? No. But if I can give him 3 really concise, simple, easy to follow exercises and tell him I need him to do 20 of them a day or 40 of them a day, 1 in the morning, 1 in the evening, 1 set in the morning, 1 set in the evening, right? Exactly. Anthony's like, I can do that. Or I specifically say, hey, Anthony, when you're at home, or saying Anthony's now, say, 65 and he's a retiree, when Price is Right comes on in the morning, I want you to do these exercises at the first commercial of Price is Right. And I want at the evening, when you're getting ready to watch Jeopardy, when the first commercial comes on during Jeopardy, I want you to do these 3 exercises. Now I've kind of set a trigger in his brain. He's sitting there and all of a sudden Price is Right comes on, and the ad, and so first ad comes up, right? And Drew Carey's done with the first person. It's like all of a sudden, invariably, it's like, oh yeah, I got to do my exercises. If I just tell him 2 times a day, that can be a little bit nebulous to patients. So triggering events like that can be really beneficial. You say, I want you to do 1 set of these exercises once you get up and get out of bed and had your shower. And then I want you to do 1 more set of them right before you go to bed. That gives them clear times to do it and kind of sets in their head, oh, okay, right? It gives them an idea of when they're supposed to. If you just say 2 times a day, I could do 1 at 1 o'clock and 1 set at 2 o'clock and think I'm done for the day, right? So that kind of helps that compliance with HEP. And again, the fewer exercises we give them that are more concise to what we want, the more likely they are, right? If I give him just to walk even, he's more likely to complete that walk than if I give him 50 exercises. So once we kind of get out of that soft tissue area or get out of that really acute phase and get into that controlled motion or the subacute phase, right? That's where repair and healing starts coming in, right? And sometimes this gets to be a little bit more painful initially when it happens, right? Because at that point, stuff's coming in and starting to lay down. You get that proliferation phase going in, collagen and the fibrinogen and all that's laying down and trying to rejoin up all those injuries they had. Maybe you had a muscle tear, right? Maybe you tore your bicep. And now it's kind of laying down the filler fibers and getting everything lined up. And then it's eventually going to try to line those muscles up with the fibers up with the muscles themselves. You have to educate a patient again. Look, I know it's starting to feel better, right? But you're still not through the woods yet, right? The big bad wolf is still chasing you if you push too hard, like in the case of the guy that said it was a bodybuilder. He got out of that acute phase where it wasn't as painful anymore and went right back into the gym and flared that muscle up. You know, management of pain and inflammation is going to change then, right? Because we go from cold and we may start moving into some heat modalities because now we're getting a little bit out of that acute phase and we start doing a little bit more heat. Whereas in that acute phase, if we toss heat on them, what's going to happen to the inflammation?
Get worse.
Yeah, it could get worse, right? It may not, right? And that's the hopeful thing out of it if we do that, is that it may not get worse, but it definitely could, right? If you've got somebody that's already gotten out of whack, immune system, where their autoimmune system's all out of whack, and they've got inflammation kicked up, and then you put a hot pack on them, there's a chance you could kick that inflammation even into hyperdrive, right? They could go at warp speed. Now we start getting into active exercise, right? So we kind of move to that passive range motion, and we start getting into that active assist stuff, right? Where we may have them doing exercises where they're going to have, they may have a cloth and they're going to start moving maybe up and overhead, or they're on a bike and they're using the one leg to kind of get the other leg to move. You could use, like, if you've got a problem with the biceps because you have a bicipital tear, you start using that active assist until we get into full active range of motion. We start building up some endurance, right? Well, why are we going to build up endurance? Well, maybe the problem is the reason they got a tear or soft tissue injury is because they had no endurance in that muscle. Talking to some of the other cohort this morning, the graduated cohort, and the number one thing I heard from them was, man, I can't sit for 4 hours to take a test. Their test taking endurance for that 4 hours is down. So how do we improve that? You learn to sit for 4 hours. You've got to build that endurance up of doing it. Same idea with the patients, no different. Start doing some protective weight bearing exercises if they were staying off those closed chained activities. And then as we start progressing and adding stretching and strengthening, we've got to make sure we warm up the tissue. Doesn't matter if we have kind of an acute care patient, a controlled phase patient, or a chronic patient. If we're going to be doing activity with them, they really need to get a little bit of blood flowing in their body, right? Especially when we're in this controlled motion phase. They need to be doing something actively to warm up, right? We want to kind of get away from just putting them on a hot pack and calling that the warm up. Because if we just put a hot pack on them, I guarantee, and I've had this in the clinic, the patient will come in one day and it's like, man, you know what? Raquel, my back is just flared up today. I don't think I can do therapy, but I could do the hot pack today. And Raquel's standing there like, what? Are you kidding me? Ain't no, get on your bike, right? And that can happen where patients kind of get that addiction to the modalities, right? Whereas what we're doing is trying to get them so they don't need the modalities. Or they're coming in, or you see them and they're constantly wearing their TENS unit every time they come in. It happens all the time, like Oscar says, right? My thing is TENS units. I like TENS units, but in most of the clinics that I've worked in, once we get out of that acute phase, the PT often, unless we know they're a chronic patient, will take that TENS unit back so that the patient doesn't constantly have that TENS unit on, right? Because there's that diminishing return after a while, right? We talked about that in modalities, where after a while, right? So maybe you started using a TENS unit, you're at a 4, and then you're at a 5. Then you're 6, 7, 8, 9. All of a sudden, you're at a 10 now on the dial. And the patient's like, well, my TENS unit's not working anymore. Well, you've accommodated to it. There's not much we can do. We can adjust settings, but they've kind of gotten used to having that TENS all the time, and the body just has adjusted it to being an everyday occurrence. So then we're going to work on relaxation techniques, a couple breathing exercises, right? maybe a little bit of talk them through some meditation type stuff so that they can relax when they get those pain increases. So maybe they don't have to take as many NSAIDs or as many analgesics or, God forbid, opiates. And again, like, you know, the APTA was pushing, you know, and still pushes to this day, how PT is better than opiates. And it's right. I mean, I agree that certain patients are going to need opiates, especially cancer patients, right? End-term cancer patients need their opiates. They're in a lot of pain. But if I sprain my ankle, I probably don't necessarily need to be on Vicodin, right? But it happens. And so we get them moving, get them teaching them relaxation and meditation techniques that can kind of help overcome some of that pain a little bit. Remember, in those acute phases, we're maybe doing those grade 1 mobilizations. We're just doing some oscillation, right? Maybe moving a little bit into grade 2s. Now we're getting into that controlled motion. We may move up to a grade 3, or a PT may move up to a grade 4 or 5 mode, depending upon what the patient needs here. Stretching techniques for not only manual therapy, us doing the stretching, but we also have to combine us doing stretching on a patient with them doing stretching. Because, you know, say Oscar's working with this patient and he's doing all the manual stretching himself. The patient, again, just like with modalities, can get addicted almost to Oscar doing the stretching for them. And they'll come back and like, hey, I need you to stretch yourself today. Yeah, but Oscar, you do it so much better. Come on. I know I said I'd do it today, but can you just do it this one more time? And Oscar's like, I got 9 notes to write. No, it doesn't say that. But he's like, you know, we really got to get you independent, right? This is not much different than how you parents prepare a kid to finally eventually leave the nest, right? You build up independence, sometimes scale back some of their independence, then give back some of that independence. Same idea here with the patient. And then massage, we might get a little bit more aggressive. What kind of massages might we do if we've got some muscle tears? Well, we might get in there and kind of do some cross friction, where we're going to start lining those fibers up with the way that the muscle might lay. Get a little bit more aggressive, maybe some more petrissage to kind of get those adhesions lifted up. Maybe they have trigger points, so we might treat the trigger points. And the main thing is when we gain new range of motion, so when we've stretched them, we've done some massage, we've done some modalities, whatever it is, and they've got 5 more degrees. We got to get them doing functional stuff so that they're using that new range of motion, right? Reaching overhead, kicking a soccer ball if they're allowed to kick, stuff like that. And then, of course, we move into either 2 phases at the end. We can move the return to function, which is what we hope that everyone moves towards, or the kind of polar opposite of that, we move to chronic inflammation, where the patient kind of gets stuck in that repetitive cycle of injury and back to health, and injury back to health, and injury back to health, and they end up in that chronic phase. And those are those patients that just keep coming back and say, you know, Anthony, man, I know I love seeing you, but man, I'm just not getting any better. Anthony's like, are you doing your HEP? And the patient's like, oh, of course I am. What do you think I am? I'm fooling you? No, probably not. So we got to work on that maturation and remodeling of tissue, right? Get it so it's back to where it should be. The more mobile we keep the patient, right? The more mobile we keep them, the more we keep them moving. We know that motion is what?
Lotion.
Motion is lotion. Good, right? And just like before, to add to that, we've got to build stability before we build mobility, which is why in the acute phase, we build all the stability up so that we can get them mobile now. Get them up and moving, right? They should be doing more of that kind of tissues. If they end up in what's called a chronic phase or chronic pain syndrome, or where they've got a chronic pain problem, most doctors will say that in order for them to be kind of in a chronic pain, that pain has to have been with them for greater than 6 months. And so that inflammation period is kind of perpetuated. So they get better, they get worse. They get better, they get worse. They get better, they get worse. And then also, there's also usually kind of a weakening effect that goes with that, right? So that as you're in that chronic stage of inflammation, your body's not able to exit that ramp. And so you end up in this phase where kind of you get a general deconditioning of the body because you're going to start limiting your range of motion. Repetitive strain will kick in. Trauma And then also just re-injury, right? Again, that bodybuilder that I said, whoa, I thought I could go back and lift at 2 weeks after I tore my bicep. Yeah, dude, good job. Now you're probably going to tear the other one. Or worse, you're going to re-tear the one that just kind of healed, and it's going to get worse. And it will lead to contractures and poor mobility in general. So for patient education at this point, whether we're in the return to function or the chronic pain kind of phase, we've got to educate them on how to prevent this from happening in the future, right? Like right now, one of the things that helped me with my neck is I got my monitors off stands because my monitors were just on stands on my desk. And I now have them on lifts. So if I need to stand up, I can lift all my monitors up and they all go up together, right? I don't have a sit to stand desk. Unfortunately, this is kind of an old oak desk that I really am partial to. So I could get one of those cool little things like, I think Dr. Preskin has one, Dr. Soap has one that lifts up the thing as well, but I just went with monitor stands, which work just as well, right? That way, it kind of keeps me from getting that repetitive strain on my neck. So same thing, we may have to say, all right, let's go ahead, John, and let's take a look at what you're doing on a daily basis. What are you doing? Okay, well, I go to work and I sit at my desk, and every day I sit at my desk, I'm sitting kind of like this, right? And my keyboard's kind of here, and my monitor's up there, and that's the way I work, right? The very desk, there we go. Thank you, Dr. Reston, appreciate it. DMC, pop in, welcome. So what do we got to do? Well, we got to go in and educate John, right? John may need a workplace assessment from somebody that does, workers' comp, or not workers' comp, but maybe, work hardening. There's the word I was looking for. Thank you, work hardening. Where we go send, the PT or PTA may be at his job, especially like down at the casinos, they have some of these PTs and PTAs that will go out and assess kind of what's going on, what the person does, and how we can improve them so they don't get this repetitive strain. Progressive stretching, keep stretching, right? I think John asked that earlier, is really one of the only prevention methods for keeping strains and sprains of ligaments to happen is stretching. Yeah, right? They've got to keep stretching. Stretching is a lifelong thing. And I'm not going to ask how many of you skip stretching when you go to the gym, but I'd be willing to bet if I did ask that, it would be quite a few of you that you maybe go to the gym, you work out on the treadmill, you may go, or elliptical, and you may go lift, but then you skip the whole stretching part, right? Or maybe even skip the cool down part, and your cool down is grabbing an iced coffee on the way out the door or something. We also want to work on control and muscle performance, right? Building that neuromuscular control, building themselves back their high demand activities, so functional activities. Getting them, if they're a sports athlete, like kind of says the same thing. Good job, Mr. Keeper. They're an athlete, right? Let's say that, Oscar is a world-class, NBA recruit that we're working with. Well, at this point in the return to function phase, I'd better be out in the court with Oscar a little bit, right? And working with him, getting back to doing the stuff that he's going to do. Or, maybe Christina is building up to play golf again. So we go out and we start practicing golf activities. Or, I don't know, Diana works at Amazon and she's a picker and packer. Well, then we've got to look at what she does on a daily basis and kind of duplicate that. So we build a functional activity and a functional exercise that duplicates what they're going to do on a daily basis. And some endurance and strength training for long term, right? We know that that's beneficial. So with chronic inflammation, modalities and rest are important for those that get stuck in that chronic inflammation phase. So when they get really bad, they've got to rest it and know this, right? We talked about that with all of those kind of patients that, the autoimmune condition, stuff like that. When they're in a flare, they have to rest to allow that body to return back to normal. And what can contribute to patients getting soft tissue injuries, whether it's a muscle tear, ligament tear, a strain of the nerve, stuff like that? Well, imbalance between length and strength. Again, right? Guys that are jacked up and huge, a lot of those guys are really muscular and they have a lot of hypertrophy of the muscles, but the range of motion just is horrible. You ask them to move their hand overhead and they're like, yeah, I got shoulder flexion. Right? I got 60 degrees. Or, you know, you test them with a Thomas test, and you're testing to see if they have tight quads, and you do that Thomas test and you get kneed in the back of the head by their other leg because they're so tight. There has to be a balance, right? Just like everything else. I can drink coffee, right? But my coffee also has to be in balance with drinking water. Same thing here. There has to be a balance between strength and length. If there's rapid or excessive repeated eccentric demands, where you're doing stuff that is more eccentric in demand and load, and you're not thinking about it. So maybe you're constantly doing plyometrics where you're deloading and landing and having to recover and come back up against gravity. Muscle weakness, well, that goes back to that strength and length issue. Bone malalignment. Again, we've talked about this with either the Q angle at the hip because of they're causing patellofemoral pain syndrome, or maybe men with Osgood-Schlatters disease, or in general, like if my shoulder subluxes or my hip subluxes, that creates a bone alignment problem, which then can lead to a soft tissue injury. Changes in the usual intensity or demands. I did this the other day. You know, like I said, pandemic, I kind of laid back on lifting and just had worked on doing a lot of cardio type stuff and trying to kick what I thought I had COVID in my lungs out. So the other day, I'm like, I'm getting back into lifting. And I started slapping those plates on the bars like I did before I had stopped really heavy lifting. And the next day, what do you think I woke up feeling like?
Terrible.
Yeah, terrible, right? I felt like the gas station right up the road from my house. I felt like Terribles. Anyway, so yeah, my body just couldn't take it. They're like, hey, what are you doing? So you've got to build up, right? Hiking. Maybe you're not used to hiking. You think, oh, I'm just going out walking. I did that, I did that back before COVID, actually. Went hiking up in the Continental Divide over in, northern Arizona, by North NEU. And I'm like, oh, it's just hiking up here. Nothing's different. I wasn't contemplating that we're at a different sea level and I'm going straight up and straight down places. And by the time I was done, I'm like, I'm dead. Right? I could injure myself by doing that. Return activity soon after injury, right? Sustained awkward postures. Yo, brah. What up? Right? Sitting with a bad or poor posture. I really love my chair because it forces me to have that lumbar lordosis when I sit back. You know, I've seen the way that John drives down the road when he comes to school. Right? I'm shocked. That's usually more Anthony than it is John. But when you do that, right, that's poor posture, and that ends up causing long-term problems, right? Sitting here video gaming like this all day long, right? That'll wear me out, right? So even, I mean, the controllers nowadays compared to where they used to be, at least there's some ergonomics in them that are designed so that their hand grip's a little bit better versus, you know, I don't know if any of you ever saw the original Xbox controller called the Duke, but it was like 5 times the size. This is just a normal PlayStation 4 controller, right? It was like 4 times the size of this thing, and it was unwieldy, and it weighed like, yeah, it was huge, and it weighed like 7 pounds. So I'm holding that controller in a kind of constant phase like this. I'm causing repetitive strain. So all of it comes into play. Getting a better keyboard, one that tilts, can help with that, right? Anything like that kind of stuff that can help. The way I have my desk designed, when I first started teaching, I don't think I was teaching you guys at the time. I did start teaching you guys at the time. I was teaching out in my living room. And I just basically had a mobile desk, and that was what I was functioning on. And I realized, man, my back's killing me. This is not a good setup. So I had to modify my setup in order to not be feeling like I'm ancient. I've seen some of the setups you guys have. It's kind of scary. Maybe we should do that someday. Maybe we'll have to take we might actually do that for an assignment one day, is have you guys take a photo of the setup of where you actually do your schoolwork from, and then kind of everyone give an analysis of what they see that could be improved. That might not actually be a bad idea. Right? Because that's an interactive thing that we could do. And it's not picking on, right? And Anthony's like, it sounds like fun, right? It's not picking on Anthony or wouldn't be picking on John, but maybe, right, John's like, mine is terrible. It might give John ideas that he didn't think about, right? I've done that with patients where I've gone to them like, well, I can't afford an expensive setup like you have, Mr. McKeever. Do you have a book? Put a book under your monitor, right? When I was going through school, there was all kinds of, you know, rigged up stuff that I did to my setup. Amazon box, exactly. Plenty of those laying around, especially with Prime Week. Environmental factors can be big, right? And also, let me ask you, does everyone know what this abbreviation means? Anyone know? So I got no's. Socio-economic status. What does that mean? How rich or how poor you are? Stop eating sugar. So stop eating sugar. That, I mean, yeah, okay. That's not a bad idea either. We'll add that to socioeconomic status. But we talk about environmental factors and age factors, but we often forget about this, right? What if you can't afford, you know, a decent posture stuff, you know, a healthy lifestyle, right? You can't afford a healthy lifestyle. You can't afford a chair that's healthy. That type of stuff, that can play into this as well, right? You can't afford to go to PT, right? I've got a neighbor who's across the way that has a really bad ankle sprain. And I've been encouraging him, like, you need to go to PT, you need to go to PT. And he's like, well, I can't afford PT. And I'm like, if you don't go to PT, you're not going to get any better, right? He's like hobbling around. He's got one of those little wheelie scooters and stuff like that the hospital gave him. You know, that type of thing can come into play. Absolutely, right? If you're not eating healthy, you may not recover as well, right? Maybe you're eating too much sugar, like Bianca said, and you're not eating enough vitamins and minerals to allow the bone or the ligaments to heal. And then training errors are bad, right? Poor training, or worse, no training. We've all seen those people at the gym, haven't we? The people that think they know what they're doing at the gym and obviously don't, right? So bad. It's like, yeah, right? And those are the people that you're sitting there like, man, I want to go correct them, but I know that if I go correct him, he's going to rip my head off. Yeah, that's exactly what John says. It's difficult not to come up and help. I want to tell them, right? I mean, so, but all that happens, right? One of the guys I know is a DI down at Paris Island. So DI is drill instructor. And one of the big things that he's saying that they're having a problem with right now is new recruits coming into Paris Island that can't do pull-ups. Right? They're seeing people do pull-ups where they're jumping up onto the bar and like kicking their legs up, and basically it looks like they're having a seizure on the pull-up bar when they're trying to pull themselves up. And they're like, well, that's the way I learned at the gym. And, you know, that's the last thing you really want to say to a drill instructor. That's probably not a smart decision. It usually does not end well when you don't end that with sir, right? But you may have to retrain a person, right? They come into your clinic and you're a PTA, and maybe they've been doing curls all their life, but they've been doing curls wrong all their life, right? So we've all seen people that do curls like this, right? And that's where you've got to walk up to them and go, okay, hold on. All right, so let's correct this. Let's get your back up nice and straight. All right, good. We get your back up nice and straight. Now let's just work on those arms moving. Keep your back nice and tight, chin back, head up, right? And then they're all like, man, this feels weird. Well, that's because you've been doing it wrong your whole life. That's kind of where we come into play. That is why we get paid skilled therapy. We are not paid skilled therapy to give them a bunch of exercises and have them go do the exercises in the clinic, right? People think lifting faster is better, right? And it does ruin their form, right? Or they think that going every time up to muscle failure is good too, but right, everyone knows going to muscle failure is not a bad thing, but if you consistently do it, think about when you get to that muscle failure, what your form looks like. Usually it's not the best then either, right? But this is the difference between a PTA and a tech here. I mean, this is one of the major differences. A tech is going to look at these people and just be like, well, the PT told me to have them doing curls, so they're doing curls, right? Us as a PTA and even PTs have to look at that patient and go, hold up, wait a minute, something ain't right. Okay, let's start from the beginning. Let's start with the basics of this exercise. Work off the basics, build off the basics, get them to do the stuff the proper way. You are trained and you are licensed to teach people, not to allow them to do things on their own, right? One of my biggest pet peeves is when we used to go out and do employer verifications for students, where students got graduated and went out and got a job. I'd go see somebody in the clinic and they'd be sitting over in the corner typing away, and I'd be watching them for a little while, and I'd be watching them. It was one of the grads. I'd be watching them, and, oh, do you not have a patient? Oh, no, he's over there. He's independent. He can do all his exercises by himself. I'm sorry? Right? If they're independent, that's not skilled, right? We need to be challenging them. We need to be working stuff, right? And John did make a good point. Some people think that you can sacrifice form for weight. He's 100% right? So we need to be coaching them, right? We need to be there with them. We need to tell them when they're doing stuff good and tell them when they're doing stuff wrong. And not only that, I mean, that's our job as instructors too, right? When we when we correct you on your comps, we're not doing it to make John cry. We're doing it so that you guys learn as well, so that when you go out into the field, you're a better clinician. And you're thinking about that, oh yeah, Dr. Reskin talked to me about holding my head up when I'm demonstrating stuff, so that my patients mimic me. That means we also have to have good form, doesn't it? Right? And not only that, but does it benefit us to be at least in a little bit better shape than pure round? Yeah, I mean, being a little bit more physically fit sets an example for your patients. It's no different, and I'm gonna use this as my soapbox before we go on break. It's no different than the COVID vaccine. You guys are going to be examples for the community as healthcare providers, right? If you're going to be an example for the community, you should set that example and get vaccinated. So you're not only protecting yourself, but you're saying, I'm saying right now by getting vaccinated that I value Diana, Bianca, Brooke, John, all of you guys are just the last people that posted here. I value your lives so much that I'm going to vaccinate myself so I don't get you guys sick. Right? That's kind of the way we're going to work with patients as well, right? That training them and telling them, it's okay, we're here for you. We're going to correct your problems. Which is a perfect place to break, because the next thing we're going to talk about is nerves. So I'm going to pause the recording here. We're resuming recording. We're back from break, and we're going to now move on to some peripheral nervous disorders. I mean, even part of this could theoretically be considered some central nervous, but not true central nervous. We're going to talk about some spinal cord stuff a little bit. So we're going to talk about this. Like everything, John thanked me for, I do a little bit of anatomy with everything. And so we're going to talk a little bit about the nerves themselves, right? So the nerves themselves, remember when we have nerves, we have both the efferent and the afferent nerves. Do you remember that from way back in anatomy? Where we have one that's motor and one that's sensory. Okay, good. I'm glad that we remember a little bit of that. Good, right? And then we have some sensory nerves or some afferent nerves that go to like our skin and, our proprioceptive type stuff. And then we also have some sympathetic that go to the viscera, the blood vessels, that are in the smooth walls of the vessels that detect everything like that, right? So we have a little bit of everything that goes on there. We're also going to next semester, when we review pain a little bit, we're going to go into talking about the different A deltas, A betas, or alpha beta, A deltas, A betas, A gammas, when it comes to pain sensation nerves. We're not going to hit that today because we're not really truly going over pain so much today as just nerve problems themselves. So we got our alpha motor neurons and our gamma motor neurons, right? So the alpha go to the skeletal muscles. And the way I always remember that is, if I'm an alpha male, I've got my muscles pulling out, I'm going, right? So the alpha motor neurons go to my skeletal muscles. My gamma motor neurons, right, are kind of, they go to they not only go a little bit to the skeletal muscles and they provide a little bit of the fine motor control, but they also go to some of our internal organs and some of our stuff like the diaphragm and stuff like that as well. Then we have our sensory neurons, right? That the cell body is located back there in that dorsal ganglion that go out to all of our general senses, proprioception, baroreception. What was baroreception again? I forget what
Pressure.
Pressure, good, right? And proprioception meant what again?
Pain?
Not pain, that's nociception.
Oh, yeah. The sense of something.
Like where your body is in.
Where you're at.
Yeah, where you are in space, good, right? Versus thermoception,
Temperature.
temperature, good, okay, good. See, those all come back to you guys, right? So we have those sensory neurons that go out to everywhere that have kind of sensory end plates. Then we've got our sympathetics that go out to our visceral, our sweat glands, control all of the sensation there, right? They're the ones that are responsible for Pilo Erection, right? Pilo, because they work together with some of those gamma motor neurons to trigger Pilo Erection. That is not what you think it is, John. What is Pilo Erection again?
The fever temperature?
That's pyrexia. Yeah, it's hair fibers. Good, right? It's where your hair stands up on end, right? So, like last night when all my doors closed in my house, like I had Pilo Erection of the hair back on the back of my neck because my hackles came up. I'm like, hey, wait a minute. Do I have a ghost in my house? You missed the ghost story earlier, Dr. Reskin, if you're still here. Oh, no, she left. Darn it. She'd been freaked out about a ghost story. So, yeah, so all of those are existing out there. So now, here comes the question I get, Mr. McKeever. That's okay, Amanda. There's no such thing as a bad guess. Any guess is at least you trying not to be a blank. That's the thing. And that's one of the things I'm trying to beat into you guys, that at least guess. How much of this do I have to know? Well, you need to understand specifically that your motor neuron cell bodies are in the spinal column themselves, right? You learn that in anatomy. You also need to know that the sensory neurons, most of their cell bodies are back in that dorsal root ganglion, right? So that little kind of lump back there. And when I said, remember I talked about ganglions growing on nerves? Well, if you get a ganglion somewhere else on your nerve, it literally looks like that. It looks like a little humpback whale in your nerve. When you have those weird sympathetic ones, sometimes they have a little trunk root ganglion further out. But the main idea is know that most of your sensory nerves exist back there at that sensory ganglion, or the dorsal root ganglion. When does a nerve become a peripheral nerve? So, here we got the spinal cord. We know that the spinal cord is the central nerve system, right? When does it become, when is the official time that it becomes a peripheral nerve?
Is it like when it ends up, or when it starts to be the rami?
Okay, good. That's a really good comment. And sensory foot is distal, okay. So what they usually say is on the anterior side and the posterior side, you have these things called the horns. Do you remember that from anatomy? You have your ventral horn and your dorsal horn, right? That's kind of that last little bump out there on the spinal cord. So you have the anterior and the posterior horn, or the ventral and the dorsal horn, whichever you choose to name it. Typically, they say that a nerve becomes peripheral, whether it's a motor or a sensory nerve, once it exits that horn cell. So once it jumps out of that horn cell, now technically, a sensory one becomes truly peripheral once it leaves the dorsal root ganglion, but we don't make that distinction very often. Like myself, I've got my spinal cord injuries here, right at that horn cell. So technically, I've got a central nervous system issue that triggers a peripheral problem. So once it leaves that horn, then it becomes a peripheral nerve. And that's both for sensory and motor, because again, sensory and motor are all our peripheral nervous systems. All of our nerves have a little bit of play in them, or what's mobility. They all have a little bit of stretch to them, right? It's set up so that if there's X force applied to the nerve, it can be dispersed along the whole nerve. Oh no, we're talking about algebra. No, it's not that difficult. Don't worry, don't freak out. So what it says is, if I pull on a nerve at my toe, the force that I apply on the nerve of my toe will literally go the whole way up to my brain. It will spread the whole length of my peripheral nervous system and my central nervous system in order to keep that nerve from ripping, right? It's designed that way to kind of disperse that force along the whole nerve. And we can actually do that when we're going to do some nerve glides in class. You'll find that simply moving your head will cause your toes to go to sleep if we put you in a specific position, because that nerve is contiguous. It never stops. It starts all the way up in your brain, goes all the way down to your pinky toe. That's one nerve. There's not a cut where it stops being a nerve. The nerve structure is not a taut line. So it's not like I'm taking, you know, this thing here and I'm pulling it, it's tight, right? It's kind of like a telephone line. So, you know, if I wind this up, it kind of lays with a little bit of slack in it so that when the birds land on it, they don't break it, right? Same idea here, so that when I move the nerve doesn't rip. Surrounding the nerve, right, we have the epineurium, the perineurium, and the endoneurium. Oh, wait a minute, that looks a lot like what we were just talking about with the muscles, doesn't it? Huh. It is a little bit more important to remember the parts of the nerve than it is the parts of the muscle, because we're going to talk about problems that occur when you get nerve damage, and those will involve each of these parts. So the epineurium is going to be what?
On top?
Yeah, the outside, right? Yeah, it's the top layer, right? And then we get down to the perineurium, which peri means within or around. Good, right? And then the endo, right? When I think of endo, I think of Endor from, think of Endor from Star Wars, and it's the inside. It's the small Ewoks, right? It's all the stuff inside. So the endoneurium is kind of that stuff inside. So peri, right? So you have epi, peri, endo, kind of laying in layers. It's almost like, if you remember back to anatomy, talking about there is something that surrounded the brain and spinal cord. I can't remember what those layers were called. What were those things called again that protected the brain and the spinal cord? The meninges. There we go. Right. Good. The dura mater, the pia mater, right? And the arachnoid matter. All of that kind of surrounding the thing, right? Same thing with the heart. Joe actually mentioned myocardium. He's exactly right, right? We have an epicardium, right? A pericardium, an endocardium, and a myocardium. So all of that comes into play. The names don't change, right? So good job, right? And if you go down to those, the maters, the maters, right? The hard mother, the soft mother, and the spider mother, those all have little nerves in them that also have an epineurium, perineurium, and endoneurium. So our body is pretty well designed. The nerve themselves have about 5 to 10 millimeters of extra length to them, depending upon what nerve. Like your sciatic has a little bit more slack. Why does it have a little bit more slack? Because it's a bigger nerve, right? Your baby toe nerve may only have about 5 millimeters of slack. But they've got some slack.
When you say slack, like, what do you mean? I'm sorry.
That's okay. Nope. If you have that question again, somebody else does. So if you think of a telephone wire, so here's my telephone pole, right? And here's another telephone pole. If the telephone line was taut and just straight and hard, we know that over summer, things heat up right? And they lengthen, so it'll kind of sag down. But during winter, what happens to things? It tightens up. So if the telephone line didn't have slack, a little bit of kind of a lag to it, when the winter came and it tightened up, the telephone line would rip. Same thing with your nerves. If this is your hand here, right? 1, 2, 3. So here's my hand. Out here, I've got my ulnar nerve going out to my pinky. The ulnar nerve has just a little bit of kind of extra play in it, so a little bit of extra length, so that when I bend my pinky, I don't rip it off of my neck up here. Does that make sense? So it's got a little bit of extra length to it is what slack means.
Yeah,
So
thank you.
yeah, no problem. Do I have any? Oh, I know I've got a cable here somewhere. Oh, there it is. Good old Apple cable. Not that I don't have 100 cables laying around me at this given moment. You do. Really? Come on. This is why I don't use twisty ties. I use elastic, right? So there would be what it would look like if the nerve was taut, right? And also, if I kept my Apple cable like this, what's probably likely to happen over time to this Apple cable? Yeah, it's going to rip or it's going to fail. Like I actually had one that just failed on me. It really irritated me. That would be a nerve on slack. So it's got a little bit of play so that when I move, it has range to move. And again, something like my sciatic running down my buttock there has a little bit more slack than maybe something out here in my pinky, because that sciatic is so thick, if it doesn't have that slack, it would rip right off of its length. All kinds of fun stuff to use. I can't believe I drew a hand and it kind of looked like a hand. All right. Oh, God. Do you remember these? Oh, no, Mr. McKeever, I hate you. Brachial plexus, the lumbosacral plexus. I think your rip comment comes into play also with this, when I say this, rest in peace. God. All right. So brachial plexus. Exactly. What do I need to know about the brachial plexus? Do I need to be able to remember Marmu and all that when it comes to the brachial plexus? It really will help you if you can remember most of the brachial plexus. But more importantly than even remembering what part does, where is the central cord come from? Where does the lateral cord come from? It's really more important to remember that musculocutaneous, which innervates the biceps, comes from C5, C6. That is by far more important than memorizing everything about the plexes. What the plexes will come into play is when we talk about injuries in a few minutes here, because we're going to talk about plexus injuries. The important thing to understand is we have a couple different plexus in the body, right? We have the brachial plexus, we have the lumbosacral plexus. We do have a smaller thoracic plexus we don't talk about that eventually leads to the solar plexus in the front, which is a visceral nerve group, right? So knowing what nerve roots you have, so if you remember your origins, insertions, actions, innervations, and nerve roots, you maybe don't have to remember your plexus as much. Your plexus can help you when you get questions on a brachial plexus injury, which we're going to talk about in a little bit here. But look at this. This comes back to play here again. Oh, God, Mr. McKeever, I hated these. Oh, now what do we have a picture of? What's that? Dermatomes. Yeah, I heard it. Why doesn't the face have a dermatome?
Aren't all the nerves like in their actual spots in the face?
Okay, good, right? Remember, what innervates the sensation of the face primarily?
Trigeminal.
Trigeminal and what? Well, cranial nerves, general treatment, right? Trigeminal and then
Facial.
facial. Yeah, exactly. Right? Facial nerve palsy and trigeminal nerve palsy are two problems we get in the face, right? And the easy way to remember those two, for me at least, is facial is kind of the face, right? Trigeminal, if you take your fingers, if you make a kind of OK symbol with you do opposition with that pinky and the thumb, you put that in your ear hole and lay your fingers out. Trigeminal follows that distribution. So there it comes up here to the kind of the supratemporal region, comes here out to the maxilla, right? And then comes down here to the mandible. There's a little bit of that trigeminal that goes on there. So we do have to know all of these sensation points, right? And the fun one we will learn about in next semester when we talk about spinal cords is S4, S5. That's probably everyone's least favorite nerve to test because there's really only one way to test S4, S5, right? And that is also known as the anal sphincter reflex test. And if you can think about that, that's exactly what you're thinking about. That's how you test it. And I think John asked me about this the other day, and I said, this is one of the tests that PTs usually go, here's a great test for you to do, PTA. Go complete the anal sphincter reflex test for me. Or there's another one called the Bulbospongiosis Reflex, which is even more fun. Does anyone know where the bulbospongiosis muscle is? Yeah, technically by S3, technically, Anthony. Bulbospongiosis is either the glands, penis, or the clitoris. So in that region. So there are reflexes. Sydney's like, yep, yes, sir, Bob, we will test those. So these are your dermatomes, right? Again, I told you guys, and I told the other class this morning that's out in graduation, that graduated, if you know your dermatomes and you know your myotomes, you can get through a lot of the neuro questions. You can. Oh, we test them, Brooke. There's a specific test known as the anal sphincter reflex test, or also known as the anal wink test. Yes, it is actually called the anal wink test, or the bulbocavernosus reflex test, BCR. Right? And then there's also the bulbospongiosis reflex test. The anal sphincter reflex test is either, like in a spinal cord clinic. Yep. It is more acute, 100%. Yeah. Or in a spinal, rehab setting, Truman. So for example, the anal sphincter reflex test is exactly like it sounds. You're going to glove up and you go two knuckles deep and you stimulate the skin right in front of the anal sphincter. And if you feel a contraction, that's a positive anal sphincter reflex test. Wonderful, right? Yes, that's not too much, no. There's a reason for that because the patients are probably also impacted, which means while you're testing it, you're helping vacate their bowels. And then there's the bulbospongiosis test, which combines with the bulbocavernosus test, where you stroke either the glans penis or you stroke the clitoris, and you look for a raising of the testes or a closing of the vulva. Now, you all are going, that is really awkward. I can hear it now. Brooke's like, I am never treating a spinal cord injury patient. That doesn't happen with every spinal cord injury patient. So relax. It does happen when we reassess them because we need to see if they've got those functions. And here's the deal. I'm going to tell you guys this from experience because I've done both of those tests. If the patient gets a response, they will be happy that they have gotten a response because that means there's a good chance of recovery. Because if you lose S2, S3, S4, S5, that's a bad sign. That means your lowest, it's more than motivating, right? It can move things, literally like valves. But it's a thing, they go, oh my, you test the anal sphincter reflex and they're like, oh my God, I felt that time. And like everyone cheers. Yeah, and we don't cheer, but we're like, good. Right? That means they've got some reflex coming back, which could mean they may gain some of their spinal cord loss back, which is important. It's not really what we're talking about today, but it's just kind of scare you guys a little bit. And Sydney's going to cry there. Yeah, something weird somewhere, right? And again, it's only going to happen. So let me set this at ease. It is only going to happen if you work in a clinic that is dedicated with spinal cords and if the PTs perform those tests. The patients don't mind it because here's the deal: is if they're a spinal cord injury And because you're going to set up a block so they can't see, so they can't react. If they're a spinal cord injury and they're a true kind of complete spinal cord injury, they'll never know you're doing it to them because they won't feel it, which we could get into all kinds of other discussions there, right? That could be problematic. Okay, just some business. Oh, it's your business. We're going to talk about that when we talk about pelvic health. I can't wait for that lecture when I show you some of the pictures. Anyway, that's this semester, don't worry. So when it comes to injury of nerves, right? Because we went a little off topic there, but it's kind of fun to scare Sydney a little bit. When we talk about injury to nerves, specifically PNS, the main ways the PNS gets injured is compression, where things get squished or approximated, right? When they get brought together, and specifically with sustained pressure. So like if I have an elbow contraction, my median nerve is getting squished in that elbow. And by getting squished in that elbow, it's going to have long-term compression effects. A lac or a laceration or a puncture where you can have a cut, a tear, or what's GSW? Does anyone know?
Gunshot wound.
Gunshot wound, yeah, right? If you ever see a GSW, that means the patient's got a gunshot wound. That can damage a nerve. We can have too much tension or traction on a nerve where, you know, so shear is where you kind of yank stuff at kind of like this. Tension is just straight pulling. And then what is torsion? So if this is shear, kind of going like this and with a pull, tension is like this. What does torsion add?
Sounds like an Indian bird.
Like tear.
Yeah, spin, twisting. Yep. So like you were exactly right. Like those Indian bird way, right? Where you start to cover up like that. Torsion is where you do that. So it's kind of a combination of shear and tension at the same time. So they get kind of one of those going on. That's going to be probably the worst damaging type of stuff in the nerve. Because again, that's going to be more of that like ripping with fraying. Radiation can cause damage to the nerves. Even something like excessive heat, right? If you go out and you talk to some of the homeless people that are outside, that live outside and don't live maybe down in the sewers, that sit under the sun all day long, a lot of them have lost some of the sensation to their face, either through sunburn, right, which is radiation, or it's just that they've become so desensitized from the heat that they don't have sensation anymore. It's kind of sad. Or just true radiation. Maybe you're getting radiation therapy because you have cancer. That can damage nerves. And then electricity is the big one. I don't know if have any of you ever shocked yourself so bad that you've lost feeling in your arm or something like that for a little while?
I've been tased.
Yeah, tase is one of them. There we go. Yep.
And it sucks.
Yeah. I actually when I give my self-defense courses, that especially if I'm teaching somebody that that does security or something like that, it's one of the things I make everyone experience is what it's like to be tased. Because if you're going to tase somebody, you better know what it's like to feels like to be tased. And you know, I remember back when I was moving one time, I had an ungrounded dryer cable that for whatever reason the ground had broken off of it. And I grabbed a hold of it to pull it out from the plug and it wasn't grounded. And I got 220 volts sent right through me and literally threw me across the room. And I remember sitting there going, looking at my arm and it was like this. I'm like, straighten out. My arm's like, nope, I am never straightening out again. It did not like that electricity, right? That could have damaged my nerves. We can damage our nerves that way. Look at people that work on high tension power lines and a lot of them have nerve damage. So when we classify nerve injuries, the two methods we use to classify them, put a penny in a plug, yeah, that's a nice little shock, right? 110 is not bad, 220 is pretty bad. That there's a reason why European kids don't do that, because they get a little bit more shock than we get. So when we classify nerve damage or a nerve injury, the two classifications we use are either the Seaton or the Sunderland. They're in your book, in your Therex book on page like 389. Everyone gets freaked out when we're talking on it because different neuroclinics use one of the two. They'll either talk about the Seaton method or they'll talk about the Sunderland method. It indicates the damage to the substructures of the nerve. It affects the prognosis. The worse the actual severance of the damage, the worse the prognosis. You do need to know the names of both for your boards. But the main thing that you have to understand is Seaton is more of a numeric graded system. So yes, Seaton is more of a numeric graded system, where Sunderland is more of a descriptive system. So it talks about the areas that were damaged. So Seaton is going to go neuropraxia, Axon Matrices, Neuronal Matrix. And then Sunderland is literally just going to talk about what parts of the nerve get damaged. So it'll talk about, is it the endoneurium? Is it the epineurium? Is it all of it? When I think of Sunderland, I think more of like a classification when we talk about a partial thickness wound versus a full thickness wound. Versus Seaton, I think of more of the grading of pressure injuries. So when we're talking about it, the lower level we go, so if you look down here, right, so we've got a level 1 or a neuropraxic injury, which level 1 to level 2 is considered neuropraxic. In those areas, right, if you look at it, we've got a little bit of break in that kind of basal lamina around the nerves. So that basically means at that point, there has been damage to that kind of the basal lamina, and it's not going to be, so the main thing that basal lamina is a lot of your myelin. So there's going to be some myelin around that nerve. And so it's going to be some damage to myelin. So again, technically, if you have something like MS, you exist pretty much in a constant state of neuropraxia because you damage that myelin sheath, right? And then when we get down here to what's called Axon Matrices, why is there an overlay? Because they had to make it harder. That's exactly why, John. When I grade my nerves, I grade them on the numeric scale, the 1, 2, 3, 4, and 5. And that is what most clinics do nowadays, right? Now, the main thing to understand is if I've got a 2, I could either be a Axon Matrix or I could be a neuropraxia. So it just depends upon where the damage actually occurs. And the main idea here is a neuropraxia is just a problem with something surrounding the nerve. An axomatomesis, I can never say that word. That's the A word there. That's a grade 2 and a grade 3 are where there's damage to the axon that is going away from the nerve. Does that make sense? Oh, is it 390? Oh, God. Excuse my language. I'll correct that on the slide. Sorry, 394. I sort of got to just check that. I looked at this morning. Oh, never mind. I'm an idiot. I might have the wrong rehab book home here with me. Sorry, guys. I've got the 5th edition. I didn't think about that. Thank you. I will correct that on the slide. And then when we get down here to this neuronal matrix, now we're getting damage to the whole neuron. Right? So if you look, when you get down here, we're losing a lot of that nerve. It's still occurring in the axon. None of these are occurring at the actual nerve body or the cell body. These are all going to be, typically when you have damage to a nerve, it's going to be in the axon, the part that's leaving the cell body, right? So if you remember, if we describe it, right? So we have our cell body here. We have our axon that goes away. And then we've got all of our little tendrils. And what are those little tendrils called that go to the nerve? I can in a second, Brooke. Dendrites, I heard. Yeah, the dendrites. Good. So what would a question look like on the boards about this? So you're already kind of ahead of me on this. So a question on the boards would probably, and again, is there going to be a ton of questions on the boards about this? Probably not. So just to set you a little bit at ease, a lot of times what they'll say is, so they may ask you something along this lines here. Let me just get out of drawing or text for a second. They may say the difference between Seaton nerve grading for injuries and Sunderland is Seaton is based on and it would be a numeric system versus a descriptive system for Sunderland. That could be a board question for sure, Brooke. And I've actually seen that board question before where it's talking about it's kind of like the difference between RLA gait and traditional gait, right? RLA is more neuro-based, whereas RLA is more musculoskeletal based. Same idea here. Seeding is a graded or a numeric system. Sunderland is more of a descriptive system, talking about looking at the actual individual layers that are affected. The other thing they could ask is, they may say, let me actually type, because that way I don't look like I'm writing and I can't write. Which of the following patients would, let's expand this out here, have a worse prognosis of recovery from a neuronal injury? So it looks something like that. Yeah. So at that point, it would be Neuronal Matrix, right? It'd be A. Good, right? Could brachial plexus be the right answer? I mean, theoretically, brachial plexus could be the right answer, but we don't have enough information on what type of damage we have, right? Just saying a brachial, like if I come up and I squeeze Anthony with the Vulcan death pinch, and Neuronal Matrix is a Seeding description. It goes along with the numbers. Right? So literally when we get down to Sunderland description, they're just going to label the areas that are damaged, if that makes sense, Anthony. So they're going to say that the endoneurium is damaged. That would be a Seeding or a Sunderland type answer. But they're not going to ask you, I guarantee, they're not going to ask you Sunderland. If they're going to ask you, it's going to be Seeding. Because most clinics have moved on to Seeding scaling. And then I saw a question, I missed a question when we said neuropraxia isn't an injury necessarily to the nerve itself, but it's the stuff that's helping the conduction. Yes, you're correct, John. Yes, so Neuronal Matrix would be both 4 and a 5 level, yes. And obviously 5 being the worst, right? So when we're talking about this, a level 5 is the type of injury that I have to my sensory nerves on my neck. Does that make sense? Because I have no damage there. Oh yeah, you're right. 3, I forgot it goes up that high. I'm sorry, I'm looking at my own drawings. Yes, so it could theoretically be 3 through 5. But again, most of the time when you get a question about your boards, they're gonna ask you which is the numeric system or which is the descriptive system. You have to know that. And then just know how it progresses, right? Like most things you're gonna find, the higher the number, usually the worse off they are. Right, so it'd be easy if they said which is a worse, a grade 1, a grade 2, a grade 3, grade 4, a grade 5 nerve injury on the Seeding scale. And that's where you just go, well, 5's got to be the worst because 5's the highest number. Does that make sense? So again, you don't have to memorize everything about this. I just want to make sure that you guys understand that it exists. Which one is the numeric system? And then which one is the more descriptive system? They're not going to give you a picture of a nerve and ask you to define what type of a nerve injury it has. Why are they not going to ask you that?
Wouldn't that be diagnosis?
That would be diagnosis. Good. Right? So you just have to understand that if a PT says that a patient has neurotomesis, that it's either a level 3, level 4, or level 5 injury of the nerve. So a lot of times, though, if you see it in the clinic and maybe you encounter somebody that they've seen a neurospecialist, they will say that the patient has a neurotomesis of the, let's say, muscocutaneous nerve that is a grade 5. Does that make sense? That help clarify it a little bit? So then you know that it's a tear through that nerve, that axon, right? And it's a pretty bad one at that point. And there's probably no signal leaving that cell body. And it would also have to indicate whether it's a afferent or efferent nerve, right? Whether it's the muscocutaneous nerve that innervates the skin or it's the muscocutaneous nerve that innervates the muscle. So what happens for recovery? Well, here's the big thing. The nature and level of the injury is going to be the main dependency, right? How long until you get it repaired? That is why I still to this day have nerve damage, because it took them 3 months to get me in for surgery because they were a bunch of jackwagons. How motivated they are. The reason I have motor response back is because as soon as I could, I started doing motor stuff. And the age, right? The younger you are, the better you are. Studies say that 1 millimeter to 5 millimeters a day is the regrowth, but other texts will say that your nerves only grow about 1 centimeter a year. So what does that tell us about nerves? We don't know enough about them. We know that there are some regeneration factors there, but we really don't know if or how they're going to regenerate, right? If we can figure that out, if we can figure out how to trigger regeneration, we theoretically could solve spinal cord injuries, right? We could do STEM from what was that movie? I don't remember what that movie was. That was a really blood-showy movie where the guy got the implant in the spinal cord and all of a sudden could walk again and it took control of his body. But I highly recommend that creepy movie if you get a chance to watch it. If you ever see somebody that says they have Wallerian degeneration, this is where literally the nerve fiber, the axon itself, gets ripped off the cell body. And again, this is not like that nice cut like the Seaton or the Sunderland shows. This is literally, it avulses from the cell body, the axon does. If it avulses from the cell body, typically it's not going to regenerate. The key time frame here, and this is something you guys do kind of have to know, is 24 months. And some books will even say 12 months, but 24 is the hard, this is like the absolute hard outside factor. What you have at 24 months or 2 years is all you are ever going to get back. So if at 2 years, like I'm well past 2 years, I have never gained sensation back in my hand, right? Am I ever likely to gain sensation back? Again, my injury occurred, yeah, no. There's a good chance I'll never get it. Does that mean it won't spontaneously come back? Sure, like there are some days where I'm like, God, it'd be awesome if I randomly got some sensation back. But I also know some of these problems down here occur, and that kind of terrifies me, that I don't want it. So at 24 months, so at 12 months, if you haven't started working on it, you've got problems. You're probably not going to get much back. At 24 months, whatever you have is what you're going to get. So it's almost the same for a spinal cord injury, that at 2 years, whatever they have is what they're going to have for the rest of their life, or they're going to decline as well. So what can happen if the nerve regenerates? Well, the good news is the nerve can regenerate right back to where it should. So you get complete neural regeneration and your patient is just peaches. That's ideal, right? That'd be perfect, right? Truman gets a nerve tear on his ulnar nerve and it regrows and he gets his pinky movement back. Truman's happy. That's perfect, right? You could have exact reinnervation where it grows back with no return to function because the stuff that is reinnervating has degenerated. So let's say again, maybe it's, I'm going to use my ulnar nerve as an example. So I got an ulnar nerve tear here just distal to my wrist or proximal to my wrist. And all of these muscles in my hypothenar eminence and my fingers degenerated. And so they're now all completely wasted away. But 3 years from now, or 2 years from now, that nerve regrows. Well, that's great. I've got reinnervation of the tissue, but everything in that area has basically died. And not dead as in like necrotic, just that it's not functioning anymore. So at that point, great, I've got full reinnervation, but there's nothing I can do for it. And I have seen that happen, and that is extremely frustrating because what usually comes back at that point is sensation. And it's super painful because now they can feel that their fingers are contracted. And they're like, I just want to extend my fingers. And they're telling their brain, and they can kind of feel some muscles down here quivering, but they just can't get those fingers to extend. And it gets really frustrating for a patient. Yep, that's what we're going to talk about right now. So Riley asked, does synesthesia ever occur with wrong receptor innervation? Yeah, that's what we're going to talk about right now. So right there, wrong receptor reinnervation. So this is where you get either improper input or improper output. So this would be a case where a sensory nerve goes back into a motor horn, or a motor horn goes back into a sensory horn. Oh boy, that's going to cause some problems, right? This one here is one that I actually encountered in my life one time for a patient. So synesthesia, which is what this is called here, right? Synesthesia is Riley properly spelled it. I can never spell it. And then we have this form of synesthesia, which is actually worse. This is where the nerve grows back, but grows to the wrong area. So I had a patient once that ended up with a partial tear of, or actually it was a full tear of their axial nerve. Right? And so when it grew back and re-innervated the bicep. They still had their musculocutaneous nerve, but that grew back in along with it. And so if you told the patient to flex their elbow, they'd flex their elbow. If you told them to extend their elbow, they'd flex their elbow, because the triceps had no innervation whatsoever. It was really weird. And the patient would go, I'm straightening my arm. I'm telling it to straighten, and it just bends. And so they did some nerve conduction tests and found out that the nerve actually regrew in the wrong place. And he had basically bilateral, or not bilateral, it's not a good term. Bineuronal, I think is the term. Bineuronal innervation of the bicep. Which also became problematic because one of the things that happens is reciprocal inhibition. So initially, it was just bad luck. Yeah. So initially, he had normal biceps function. But what happened over time, as that nerve regrew and regrew, do you remember what reciprocal inhibition is? We talked briefly about that. So reciprocal, I'll spell it over here.
Is that when like your brain is telling your body to do something, but it just won't, like, you know how to do it?
Not quite.
Oh.
That's okay. No, don't do O. You answered. You risk to put yourself out there more than 23 of them. So remember, reciprocal inhibition is if I tell my bicep to contract, what does my tricep do? My tricep has to relax. Yeah, elongate, right? Because if I tell my bicep to contract and my tricep contracts, I'm just kind of stuck there, right? I can't move. So the nerve that innervates the tricep, when I move my bicep, the nerve that innervates my tricep says, relax, buddy, you don't have to do anything. The bicep's got you. And then when I extend, my triceps contract and my bicep relaxes. That's reciprocal inhibition. It's where one muscle contracts, the antagonist relax. What the patient had was apraxia. Well, actually, it's ataxia because they had the motor plan. Remember, P is motor plan. Ataxia is the plan is intact, the muscles or the nerves are screwed up. So later on, what happened as that nerve regrew and regrew, now when he was telling his arm to bicep to contract, the musculocutaneous was telling it to contract, the axillary was telling it to relax. And so his arm just did one of these and just kind of quivered. And so what they had to do to fix that is they went in and did an ablation where they burnt off that nerve that was wrong. And they just basically cauterized it off so it wouldn't grow back. So at least he had flexion of the elbow, even though he lost extension. And so how do you think he extended the elbow then?
You would have to
Relax.
Yeah,
he'd relax his bicep, right? And what would cause it to extend? Gravity. Right? So he'd pick stuff up right? If he was lowering stuff, he would use eccentric control of the bicep to slow it down and typically use the other hand. But then when he needed his arms to straighten out, he just relaxed the bicep and let gravity take over, right? He could never throw a ball. No. I mean, theoretically, we could teach him to use reversal of muscle action, but it wouldn't be very effective. There goes his NFL dreams, you're right. Or basketball dreams. Maybe he can play for the 76ers. At this point, all my sports teams aren't doing the smartest moves here, so I can't really say much. All right, so does that overall make sense, though? And again, like Truman said, Truman had the right idea. Actually, all three of these, so the exact reinnervation with no return to function, wrong receptor innervation, or false input-output, all of these are ataxic problems. Because your brain knows what it's doing in order to move, right? But there's something wrong from the brain down. It's not working. That would be an ataxic problem. Uh-oh, what did Dr. Arrest can say to you guys? That wasn't for you guys. That was for me. She was saying, thank you for letting me stop in. Isn't that nice of her? All right. And yes, you need to know these. 100%. You need to know them backwards and forwards. So just to let you know, what are the outcomes of nerve regeneration? If we have nerve injury recovery, again, we're going to go through those same phases, the acute phase, the recovery phase, and the chronic phase, right? In the acute phase, movement will be dictated by the doctor, right? Usually passive range of motion. We're going to be splinting to prevent deformities and mainly patient education. Recovery phase, we're going to start retraining the motors, basically through NMES and active assist range of motion with gravity eliminated. We may have to do desensitization if it is a sensory nerve, because most nerves grow back really hypersensitive. Start working on discriminatory sensory re-education. So retraining them to what pressure feels like, what touch feels like, what heat feels like, what cold feels like. And again, patient education. And then the chronic phase, if it doesn't recover, then we got to teach them how to compensate for it, right? One of the compensations I've learned from having no sensation as this hand is I don't touch hot things with this hand. I don't touch really cold things with this hand because I can't tell if it's going to damage my skin. I still do cool tricks where I can stick my hand in a bucket of ice and sit there for an hour, which probably is bad for me, but I've learned through my own training that I can't really do the same stuff I would normally do with this hand, right? If I have a compression neuropathy, when adjacent structures can constrict the peripheral nerve, a lot of times there will be limits in the blood supply to that nerve. So we need to relieve that compression, or in a case of entrapment, when the nerve is restricted by connective tissue, we also have to treat the entrapment. So if it's compressed where it's being squeezed by another structure, we have to take care of that squeeze first before the nerve will ever get any growth back. If it's entrapped because it's stuck in the sheath, we have to break it free first before they can get into recovery mode. And that's happened on people with like sciatica, where the sciatic nerve has literally bound down, not bow down like Ice Cube said, bound down to something like the piriformis. And the surgeon may have to go in and do a nerve release where they release that nerve from the piriformis so that they don't get pain. So we have to relieve whatever's causing it before we can get to recovery. Nerve mobilization techniques. This is one of the things that I actually had a couple of you ask about. Are we going to do this? We are absolutely going to talk about this. But before we mobilize, we have to make sure that the PT, first of all, does all the necessary tests to make sure that the patient is a candidate for nerve mobilization. Because we can damage nerves really easily. Is this a PTA skill? Yes. Some PTs say it is not, because they'll say that this is just like a joint mobilization, and this is more of a PT skill. I say it is because it's no different than stretching other soft tissue. Will you be expected to know this for your boards and possibly for your clinics? Sure, that's why I added it to this semester, so that maybe this is another thing you can add to your wheelhouse and have in there. So you guys can read through the top part. We're not gonna, this whole, like, what can cause or what we need to do before we do it. Great, congratulations. What we really need to talk about are these two principles of management. So when we are mobilizing a nerve, there are two different techniques. There is flossing and there is gliding. Flossing is also known as sliding. Gliding is also known as tensioning. So when you floss your teeth, what do you do with the floss? You take it out, you put it between your teeth, and you move it back and forth, right? Remember that from, so those of you that do floss your teeth, or maybe you got one of those water picks, who knows? Or maybe you never floss your teeth. A glide is more where you're gonna glide it to a certain point and put some tension on it and then glide off of that point. So I like to think that flossing or sliding is more like passive range of motion. So you're just gonna go back and forth, kind of moving that nerve in the sheath. Whereas glide or tensioning is more like stretching. So you're going to take that nerve out to the point where it gets a little bit of tension on it so that it gets a little stretch to it, right? Both of those, theoretically, if the patient has an adhesion on their nerve, both of those theoretically could pop that adhesion. The tensioning is more likely to pop it because it's a little bit more aggressive. And I'm going to give a demonstration just so that it makes sense, because I can already see Brooke's head exploding. Even though she's not on camera, I can see her head exploding. So flossing, passive range of motion, gliding, stretching. Those are the two things, right? So flossing is just passive range of motion of the nerves. Gliding, think of stretching. What nerves can we do this to? Well, a bunch of them, right? But we have to know some precautions. If there are any type of tissues that are affected by it, we have to make sure we understand that. What makes their pain worse? What makes their pain better? We have to know that, because that can clue us into how we're going to do our glides or our flosses. We also have to know all their other conditions and watch for signs where we compromise the blood supply, because in some of the positions we're going to put the patient in, it's also a provocation position for poor blood supply. So if a patient has something like peripheral artery disease, and I put them in a position for radial or for ulnar nerve testing, that can also constrict blood flow to the hand. So we have to make sure that the patient is healthy enough to do these. And a PT decides that, not us. There are some contraindications. Any acute or unstable neurological signs where they have really, really bad neuropathy that's just super intense. Well, we probably don't want to move the nerves because we're probably going to make it worse. Cauda equina, we will talk about next semester. That's where there's problems with the bowel and bladder due to the cauda equina of the spine. If the patient's got a spinal cord injury, I've got to be careful. If I've got a patient that's got a T5 spinal cord injury and I'm doing nerve glides of the hand, I'm okay because that's above the level of injury. But I'm not going to want to do nerve glides of the legs because now I'm going to be pulling on where that spinal cord injury is. Does that make sense to everybody? Because again, when you have a spinal cord injury, they're named for where they have function at, basically. So like in the case of my hands, I would definitely not want to do any nerve glides or flosses if I've got a cervical level spinal cord injury, because my hands have nerves that start from there, right? If you wanted to be safe, how far down the thoracic vertebrae would you want to be before you start moving the hand nerves around? So Anthony says T2. I'm going to take that one step lower. I'm going to say T3 because there are some parts of T2 that are back here. So T3 is kind of your first stable level. So if a patient is like T3 or there, you're okay. If the patient is a C2 injury, don't do nerve glides. You're damaging the area that's already damaged. For the legs, pretty much anything. Right? I mean, short of something like at the sacral segment, it's S4, S5, but you don't usually get spinal cord injuries at S4, S5 because the sacrum's fused. Pretty much anything, if you've got a spinal cord injury, it's a no-go for leg mobilizations. For the nerves, not necessarily for the joints, for the nerves. So what can cause some common problems? If you have median nerve problems, it could be the thoracic outlet or the carpal tunnel. Thoracic outlet, carpal tunnel. Radial nerves could be tennis elbow, or it could be de Quervain's veins. Tennis elbow is also known as what?
Lateral epicondylitis.
Good, lateral epicondylitis, right? Medial epicondylitis is also known as what? It's the other term for medial epicondylitis. Anyone know? So if tennis elbow is lat epi, it's knee. Medial is golfer's elbow. Because there's a lot of pressure put on that medial epicondyle when you play golf. Again, radial nerve could be out here at the thumb, de Quervain's. Ulnar nerves, typically medial epicondylitis is one of the major triggers for it. So we have a couple pictures coming up here. So we're going to kind of go through this, and you can actually mobilize yourself without having to be in a perfect position. So this says begin with the patient supine. It's fine. We're going to do a self-mobilization, right? With the patient's upper arm on your thigh. So what you're going to do is you're going to put your arm out at about 90 degrees of flexion, 90 degrees of abduction. So kind of out here. So everyone's out like this, right? So once I have my arm out here, right? Abduct the arm at approximately 110, keep the elbow at 90 degrees of flexion. So I'm going to come here and I'm out here. Once the shoulder is at the elbow position, I'm going to extend the wrist and fingers, including the thumb, right? And I'm going to supinate the forearm. So supinate is going up, right? While doing lateral rotation of the shoulder. So I'm going to come from here, 90 degrees, extend the elbow, supinate the forearm, extend the hand back. Does anyone get tingling with that? I do a little, right? Do you feel it in your first three fingers, kind of? Right? That's because, you know, in the wrist, right? That's where that carpal tunnel is. So that's mobilizing the median nerve. It's the same thing if you did it with a patient. The only difference with the patient is you're going to move them through this motion, right? So now I want you to try something for me. Put your arm all the way on as far position as you can get out here. Turn your head away and then laterally flex it. Does that get worse? Good. What does that teach you? Other than don't do that. That shows that that nerve, anatomy is real. Good, right? It shows that that nerve goes all the way up to your brain. And Joe's saying it feels good, right? And that's a self-mobilization. It's getting stretched more. Good. Right? So be careful. These are nerve glides. Yes, that's what we're doing right now, Stephanie. So what is the difference between, if you remember back here, I was talking about a floss versus a glide. Here's the difference. If I'm flossing, it's just passive range of motion. So I'm going to come out, down, back, out, down, back, out, down, back. I may add that head motion in. But I'm just going out to the point of tension and coming back. That is just like passive range of motion, isn't it? Right? And so that is a nerve glide of the median nerve, right? So now if I go back here again and I'm looking, or a nerve floss of the median nerve, if I'm looking at a nerve glide or a nerve tension, I'm going to go out. I'm going to get it out there to that tension point. And what am I going to do? Stretch it. More importantly, what am I going to? I'm going to hold it. Yeah. So now I'm going to come out here and I'm going to hold it. 5, 4, 3, 2, 1, and relax. 5, 4, 3, 2, 1, and relax. Does the difference between a floss and a glide make sense now? Does anyone not understand the difference? Truman says yes. Diana says yes. Does anyone not understand, please? We're actually going to do that in a little bit, Brooke. Don't worry. Okay, so it makes sense. That's what I want to see. All right, so we did median. Let's do radial. Where does the radial nerve go to?
Radius.
Good, the radius, right? Goes to the thumb side, right? Okay. So if you look here, it says begin the patient supine, apply gentle shoulder depression. So you're kind of pulling the shoulder down. You're going to abduct the shoulder to about 10 degrees, extend the elbow, and then immediately rotate the whole arm, including the forearm pronation. So I'm kind of out here like this, right? Keep the elbow in extension and add wrist, finger, and thumb flexion, and finally ulnar deviate the wrist. And then slowly abduct the shoulder until they get tension. So I'm going to start down here, right? Kind of palm up. I'm going to come down, extend, flex my fingers, ulnar deviate, and bring up. Does anyone feel tensioning in that thumb? Anyone feel numbness in the thumb? Anyone here gain that feels that? Because I feel that pretty heavily in my forearm. Okay, that's good, right? Kind of in this side of the forearm here. That radial side, yeah. If you gain, it's likely this might provoke some issues in the thumb. This is one that's really good if you're a gamer to do kind of between, and the way I teach my patients to do this more than the way I did it is I start here across body, which is almost like a PNF pattern. And I come out, come up, and abduct, and bring it back in. It's almost like I'm doing a sweeping motion of the arm. And what that does, and so the other thing you can add now, let's take it a little further. Take your thumb, tuck it into your fist. Do the same thing, tuck it in, and then get out there. Does that feel any different for anybody?
I feel that up to my bicep.
Yeah, right? Now I can feel what Truman says, right? Now, let's take it a little step further. Okay, that's fine. I mean, that may just mean that you don't have radial nerve issues. Let's take that a step further. Go out there again. Tilt that head and rotate it again. Oh, that sent tingles. That's fine. What that probably means is your bicep is tight, honestly, Brooke. That's probably what that honestly means. And so that may be a case where I go, oh, well, maybe her problem's not in her wrist and her radial nerve. She's got a tight bicep, and I've got to stretch her bicep out. Which, guess what? That's one of the positions, almost the position of stretching the bicep out anyway. All right, so that's a radial side, a radial nerve. Nope, you're doing it right. It's just, honestly, John, you probably don't have, it's pretty rare for somebody to have radial nerve issues. I have it just because of how much time I spend doing this, honestly. And the fact that I used to, I'm going to admit this, I actually can knit. And that's a lot of thumb motion. I learned to knit so I could work my fine motor skills in my hand. So I tend to get a little bit more of that decor veins on my thumb. And that's one that we might work with a patient that's got decor veins. Granny Keith, exactly. All right. Now let's do the ulnar one. This is usually the one that provokes somebody in here and they're not going to like it very much. So at this point, you're going to extend the wrist and fingers, right? Pronate the forearm, right? So I'm going to end up in a position out here like this is where I'm eventually going to end up, right? Yep, we're going to do all this in lab. Yep, I just want to kind of show you these, see if we can get a feel for it, right? So we're going to come up here, right? So we're going to depress the shoulder girdle's coming down just a little bit. Abduct the shoulder at about 110. So I'm going to come out here. I'm going to bring the arm up into external rotation, right? I'm going to pronate the forearm and extend back my wrist and then try to radially deviate slightly. So this part of my arm should be kind of out like that. This looks like I'm holding a platter, right? If you're one of the servers. And guess what? People that carry trays like that, guess what one of the complaints they have is? Ulnar nerve pain. Because holding a tray like that. Feel it in the pinky and the ring finger, yep. Is that where you're feeling it? Or do you not feel it at all? Nope, it just means that you don't have, so here's the deal, Brooke. Well, that just means you have a tight ulnar nerve, that's it. And so that's one that you can do to help increase a little bit of mobility of that ulnar nerve, right? So again, I wouldn't do the tensioning because again, tensioning I tend to not do very often with my patients. I do more of just that flossing where I'm getting that nerve to move in its sheath and loosening up a little bit. I'm going to come out and back and come out and back. There's a test where you can turn your fingers upside down and look through the thumb. I can't do that one either. That's one of the things. Sciatic nerve 1. Oh, this is a fun one. In this one, you're going to do a straight leg raise to the point that you keep the knee straight. So if you lift up the patient's leg and their knee starts bending, you've gone too far. You've got to keep that knee straight. So think about if I'm pronated here and I externally rotate, I'm still pronated up here, Amanda. I'm just now externally rotated at the shoulder. Right? Pronated here, externally rotated. Does that make sense? So pronation is palm down. That's okay. So if we think here, supinated, right? Pronated. If I just do it through motion, pronated, abducted, externally rotated, and then I'm going to try to radially deviate with my fingers as extended as I can get them. I can't really radial deviate because I have no radial deviation. Like none. So this is the one that by far most of us will hate when we do it. Because this is going to not only stretch the sciatic nerve, but it's also going to stretch the sacral and lumbar plexus. It's also probably going to stretch some of your calves out. So you can do this yourself. You just have to have kind of a belt and you have to lay down on the floor. So in this case, what you do is you're going to bring your leg up so that the leg is straight. Again, you want to make sure that the knee stays straight. If it bends, you've affected the actual pull of it. Once you have that knee as straight as it can get, doing a straight leg raise, you're then going to take the foot and dorsiflex the foot. So I can kind of do it just sitting here if I change my camera real quick. There we go. So I can kind of do it just sitting here as long as I keep my legs straight, right? I'm going to lift my leg up, and then when I get to the highest point I can, I'm going to dorsiflex my foot. And for me, my problem is not my sciatic nerve. My problem is my calf is too tight. But when we do this in the clinic and we practice this on each other, you're going to get past that point of calf tightness. So it's going to stretch the calf a little bit, but these people will feel it up there in their sciatic. So if you come out to the side, sit in your chair, straighten your leg out a little bit, straight out in front of you, lift it off the ground slightly, but keep that knee straight. Dorsiflex the foot. Do you feel tightness when you do that? Does everyone feel a little tightness when they do that? Right? Probably in the calf, right? Okay. Now, do me a favor, look away from that leg. So if it's right leg, look away from it. And then do a chin tuck. Tuck your head all the way down. Do you feel anything change out there? Okay, Riley's like, no.
Like less tight.
Okay. Why do you think that is for you? Why?
No clue.
Okay.
It's more tight.
Some of you are more tight. Okay. Some of you are more tight, some of you are less tight. It depends upon where your tensioning is occurring. So if you feel more tight, right? Yeah, right. Some of you are creating slack in the nerve, some of you are creating more tension in the nerve. And again, it can be really weird by patient. When I bend my neck like that, I've actually reduced the space in my neck, so it's produced a little bit less slack down here. But for some people, what that does is because they've got tension above that sacral plexus, and a problem maybe in the low back or something like that, that actually increases the tension. So for those of you that don't have a ton of tension in your low back, you maybe feel a little bit of relief with that. Some of you, like Diana said, it stays the same. And I guarantee, Diana, when we do it on each other, it will not stay the same. You will feel a difference. It's better if you can have a belt. Looks like you feel a little better after, right? And that's what most patients feel. It's better if you have a belt, then they will help with sciatic. So let me go grab a belt really quick. It's just out here on the side of my thing. So I got my good old faithful gait belt here. This can simulate my clinician. So it's better if I do it supine. So I'm going to lay down on the mat or the floor real quick. I'm going to lay down on the mat real quick because I have a mat here at my home. I'm going to put my belt around my ball of my foot. I'm going to lay back, bring my leg up until my knee starts flexing. From there, I'm going to let off to where it's straight. I'm going to relax my neck on the floor, and I'm going to pull my foot back in the dorsiflexion. And I definitely have sciatic doing that. I can then flex towards it, and that's going to relieve some of my tension. Or I can flex away from it, and that will increase my tension. So if I flex towards it, I'm going to help compress some of it and relieve some of that tension. If I flex away from it, it should increase my tension if I have sciatica. So Amanda, if you have sciatica, that should technically make it worse laying down. It's a little bit better laying down than it is sitting in a chair. I was just trying to use the chair for an example. So again, I'm going to keep that knee nice and straight. Again, if I come up here and bend that knee, pulling in that dorsiflexion doesn't do anything. That knee has to be straight. And then I'm going to pull, and holy crap, does that hurt. If I keep the pull, I am tensioning. If I pull and release, pull and release, pull and release, that's gliding. I could, yes, absolutely, Anthony, I could do that as well. I could flex and extend the knee, and I could floss that way. Or I could move the foot up and down. That would be another form of flossing. And it would depend upon where I think my adhesion was. Right? Most of the time, your adhesion is going to be up here in your butt.
So are these gonna, I mean, I don't want to say cause pain to the patient, but are these gonna feel good for our patient? Or are they gonna be
Absolutely not. No. You're going to tell your patient when you're doing these, this is going to be uncomfortable, but you will feel better afterwards. Like Brooke said, she feels good after some of these stretches. Right? No pain, no gain, you could, right? Is there a benefit of doing, you mean the knee versus the ankle? Is that what you're asking, John?
No, I meant either let's say doing sliding over gliding or
sliding over flossing over gliding. So yeah. I have had better results with flossing. I'm just going to say it out. And this is anecdotal. This is me as a clinician. This is not, the research. There's not a lot of research on which is better, to be 100% honest. what I have found is, yeah, it's a little bit less painful too, right? They tolerate it a little bit better. Yeah, sorry. Thank you. I'm talking to the monitor and there's no one there. There we go. I appreciate that. Thank you, John. And the main reason I was going to go to the next floss. So what I have found myself is I do it, and actually now that I think about it, I do a combination, John. So I will do 10 flosses and 1 tension. Does that make sense? So I'll do 10 off. 1, 2, 3, 4, 5, 6, 7, 8, 9. And on 10, I'm like, okay, and hold. 5, 4, 3, 2, 1, and relax. So I guess I technically do a combination. Now that I think about it, like I was trying to think of how I do it with most of my patients. And I do a little bit of both, but I think the flossing themselves is a little bit less painful, like Truman said, and they tolerate it a little bit better. If I know they have an adhesion where it's really stuck in the neural sheath, the actual neural tensioning where I'm holding it is going to relieve that tension a little bit faster, if that makes sense. It's just like if you have a really tight muscle, holding it for low and slow is going to relieve that more than that ballistic, right? So how would I write that? You mean, well, first of all, I don't assess these at all. I only assess if their pain increases or decreases with it. Because again, you can progress these. Yep, as long as your PT is okay with it. Sure. And as long as it's within the plan of care. So Joe's got a great question, is how do you write this in assessment? These are ones that I tend to not assess what I'm doing with them, if that makes sense. I don't assess the tension I'm feeling in the nerve because I think that's getting way too close to diagnosing, Joe, if that makes sense. So I try to stay away from that. And I usually would, the only thing I put in my assessment is if I'm working on Diana, I'm doing it, and Diana stands up and she's like, oh my God, my back pain is so much better after that. I can then assess that after neuroglide today, patients noted that patient had decreased pain with trunk flexion. Right? Does that make sense? Yeah, I do have videos I'm going to post up with it. Yep, I sure do. And I think I'm going to do my own videos then eventually as well, because I kind of want to do it just talking through it.
And you said for us to be like, for us to do like nerve modes, a PT has to go over like precautions and indications.
Yeah, they really have to assess with the patient if they are appropriate for these. Okay. Because again, it's really easy, John. Let's say that I've got a really bad adhesion in my piriformis. That's maybe like we had earlier where it's a bony, maybe there's some bone forming on it or it's calcifying. If I do these, I could literally rip the sciatic off the spine. Now, it takes a lot of force. I can hear Sydney freaking out already about that. It takes a lot of force to rip a nerve, especially the sciatic. It takes, I want to say it's like 400 or 500 pounds of force to tear the sciatic nerve. But if I've got an area where I've got a calcification, and that creates a kind of a flex point, I could theoretically rip the nerve. So you've got to be a little careful. They've got to have clearance for it. And they've got to have said, I would like you to do nerve flossing with this patient. Or, maybe I think that I'm working with John and I'm like, man, John's not getting any better on his low back. And I go to Dr. Wrestling and say, hey, can we try some nerve flossing with John? And she puts me in a goal for it, then I can go and do it. Or adds that I can do nerve flossing. Sure. As long as the PT has approved us to do it. That's the main thing. All right, slump sitting. This is pretty similar to what we just did. This is kind of what I was showing before. In this case, I'm going to switch the camera again really quick. In this case, I'm going to grab a hold of that patient's foot. I'm going to bring it up to 90. And I am going to, with the patient, kind of hold their foot there, put their foot in a little bit of dorsiflexion, and then cause them to slump forward and back. Forward and back. So I am literally slumping my whole thorax, right? So if I'm here, I am slumping my whole thorax and my cervical. And I can come up and put some extra pressure on my cervical region. And that, oh boy, woo-hoo-hoo. Looks like I felt that one in my hip. Yeah, right? Was it kind of a burning tingly or was it tightness?
It was like a quick, sharp pain.
Yeah, and so you might have had a little bit of adhesion back there. If it's quick and sharp, guess what? You might have broke up that adhesion. Or if it keeps going, then we might have to work a little bit, or the nerve's a little tight, low back and back of the legs. Yeah, I got that right up there in that sciatic, like right in my butt. I'm like, oh boy, I felt that one. And again, if I'm going to floss that or mobilize that, I could do head I've switched camera. I can go over here, right? I could do head motion only, right, and trunk motion, or I could even put them into that trunk slump and mobilize the foot. I could also bend the knee and extend the knee. So there are a bunch of different motions I could do. And most of those are going to be play with the patient, figure out what works. The next one I can't really demonstrate because there's no way, I don't have anyone to help me with this really. Actually, I can, now that I think about it. Hold on, I can demonstrate this one. I am a master at demonstrations. So this one is going to be the femoral nerve glide. So what you're going to do, and make sure that I got myself in view here. I do. I'm going to lay, I want to ideally put a pillow to force me into a little bit of hip extension, right? And from here, I'm going to lay as flat as I can get. You see the patients as flat as they can get. And what you're going to do is bring the foot up into extended knee, really, really extended knee flexion, and then plantar flexion. So I can do that with my strap. I can put that over the bridge of my foot. Look, it slid down some. There we go. Oh God, that actually burns. And that's also tightness in the quads. It's a lot like a quad stretch in the way it works. Because even when I do a quad stretch, I'm going to mobilize a little bit of that femoral nerve. That was a little harder to kind of demonstrate without a person. But we have to then identify, right? If I'm doing this on Riley, I think has to go to my house to help you. If I'm doing this on Riley and I ask Riley, she's like, oh, that kind of hurts. What do I have to ask her if she says it hurts? Can she
point to the pain?
Have her point to the pain, good. And then what type? Good. So can you point to where it's at and describe it? And if she says, oh, it's kind of achy and tight, well, then I'm thinking it's more that her quad is tight or her rectus femoris is tight, not necessarily nerve pain. But if she's like, hoo, that feels like I got zinging going the whole way down to my big toe, then I know it's more the femoral nerve. Does that make sense? Sharp could be femoral nerve. Yep, it could also be, I mean, sharp could also be a really, really tight muscle. If you, like Diana, if you've got somebody that's really got like for myself, I know I have really super tight quads. I get pretty sharp pain when I stretch. Nope. Well, it depends, Truman. So if my goal is to stretch the muscle and I hit the nerve, yeah, I've gone too far. If my goal is to mobilize the nerve, no, I'm doing exactly what I want to do. Does that make sense? Okay, good. So you feel free to try these. They're in your book as well, and I'll post the videos for them as well from the F.A. Davis site. All right, back to more of less fun stuff and more onto action. Are we okay on the flossing versus glide or versus tensioning? Okay. And we are going to do those. That's going to be one of the days that we do stretching. We're actually going to do some nerve glides as well. Again, I probably will not have you do tensioning on your partners, just because I find that nerve tensioning has a chance to injure a patient a little bit more, and you need a little bit more skill before I trust John tensioning on a patient. I want him to have a little bit more hands-on experience with patients before I really trust him. I know you're gentle. You're a gentle giant. I know, but I still need to. It's just like if I had you if I was your CI, I want to see you do some flossing first and check your technique before I have you really torque on that nerve. All right, brachial plexus is an area that we can have a lot of problems, right? Brachial plexus neuropraxia, where the nerve gets stretched. When does this commonly occur? When does the brachial plexus get injured very commonly?
I would say it can happen during like falling.
Okay, could be during falling, good, right? Could be during exercise, could be during whiplash, good. The main time is going to surprise you guys. It's during childbirth. Why do you think that a brachial plexus injury might occur during childbirth? Oh, somebody wants to say something.
Squeezing on the guardrails, and then like squeezing out. Just
I didn't think about it from the mom's perspective, but absolutely. Yeah, I never really thought of that. I was thinking more of the baby. And Stephanie's right, where the arm, they come out kind of shoulder first, and that's the only thing the doctor can get a hold of. That's okay. I didn't even think about it, but he's 100% right. Like, I didn't think about that, but yeah, the mom could definitely, yeah, that's okay. I didn't really think about that, but the mom could definitely do that, especially with all of the relaxin that's released in her arm. So you guys taught me something. I never really thought of that. When we talk about brachial plexus injuries, like we talked about injuries kind of the hip, oftentimes they're called stingers or burns when they're just injuries as an adult. But as a kid, we often end up with brachial plexus ruptures, right? You can end up with neuromas, which is a tumor, neuritis, which is kind of progressive degeneration due to inflammation of the brachial plexus. You can end up with an avulsion where the brachial plexus tears off. And again, I could read all this, but you guys can read all this together. I'm just going to cover kind of top level on this. You don't have to know these inside and out. The name kind of tells you what happens. If you have a brachial plexus neuroma, you have a tumor. If you have a brachial plexus neuritis, it's inflammation of the brachial plexus. If you have an avulsion, it's torn off, right? The main thing I want to talk about is what happens during childbirth. And about 2 out of every 1,000 children actually get damage to the brachial plexus at birth. And it's usually large babies or tiny mommies. Those are the 2 kind of contributing factors. Or if you have a large baby and a tiny mommy. You know, take, for example, my mom. When I was born, my mom was about 5 foot, 5'1". And I want to say she was about 105 pounds, 110 pounds. I was 12 pounds, 10 ounces. So I was almost 1/10 of her body weight. Actually, it was more than 1/10 of her body weight. Right? So, you know, yes, I was 12'10", my brother was 12'8". So, or my older brother. My younger brother, though, when he was born, it was great. She was so happy for him because he was 6 pounds. Right? But it's really easy when you're a large baby like that to get kind of bound up in mom's womb when you're coming out. And it's really easy for the doctor to get the forceps on the brachial plexus or the shoulder and literally get it. Moms can also cause that when you're a child and mom grabs a hold of arm to pull you, right? And you can get like Nurse Spade's elbow, right? Or a brachial plexus injury up in your neck as well for that. It can be blunt force trauma, athletic injuries, everything else to go along with that. But when we have a problem with the brachial plexus, we typically call those palsies. And a palsy is a damage to a nerve group. It can also be when we talk about facial nerve palsy, that's when you get that weird kind of twitch going on in your face, right? The main one you guys have to know for your boards is herbs. They will ask you questions on that. What they might ask you on the boards is the difference between Erb's palsy, Klumpke's palsy, and total plexus involvement. And that is just what nerves are affected. So here's how I remember this one. I break it down that they're alphabetical. Erb's comes before Klumpke's. Therefore, it's 5, 6, and 7. Klumpke's is next. It's 8 and T1. Total plexus is exactly like it sounds. It's the total brachial plexus. Do you have to know what kind of therapy and stuff like that to do with the patient? No, not for your boards, right? But if you think about it, if I've got a baby or a child with Erb's palsy, and I know it's 5, 6, and 7, I know that my biceps are going to be my primary muscle involved. Does that make sense? Because biceps are 5 and 6, right? If I have a Klumpke's palsy, and I know that that's C8 and T1, what kind of muscle, which muscle is going to be really affected? Or which muscles maybe? So C8, T1.
The fingers.
Fingers, good,
And
right? And the extensors, good, Anthony, right? Yeah. Right, so a lot of my hand and my extensors. If I have a total plexus involvement, what? Okay, that'll work. Klumpke's is 8 letters. Thank you. There's a great way. I never thought of that one either. So you taught me something else here, Anthony. Great job. If it's a total plexus, what muscles are going to be involved? Of the arm.
flexors and extensors?
Yeah, all of them, pretty much, right? You're going to lose pretty much all your arm and hand motion. So it's all the brachial plexus. So you've lost pretty much all of your arm motion. What do you think if a baby's got a total plexus involvement? What do you think that arm is going to look like? What do you think is going to happen to it?
Contraction.
Okay, what's it going to look like at first? How about that when they first come out of the womb? Floppy. Yeah, it's going to be limp noodle, right? They're going to be rolling over and stuff like that, and it's going to keep getting stuck under them. And then eventually, like somebody said, eventually it's going to look like this, right? Because it's going to contract up into a contracture, right? So those are kind of the ideas. If I've got an Erb's palsy, a lot of times my arm's going to end up extended to start with. Why is my arm going to be extended to start with? Because I have extensors, but I don't have flexors. So the only thing firing is my extensors. Eventually, I'm going to contract up if I get no treatment. If I have Klumpke's, I start up here because the only muscle I have is pretty much my biceps. But then as I contract, I'm actually still going to end up here, believe it or not, with even Klumpke's if I get no therapy. Because eventually, as we contract up into what I call like carrying the basket position, right? Or actually, it's basically fetal position, right? That's where we contract up and into eventually if we get no therapy, no matter what the disease is. Coroners, don't worry about. I just put it on here in case you encounter it. If any of you are going to a pediatric clinic, it's a pretty rare one, but that's T2 and T4. The main thing you'll find if you have somebody that's got Horner syndrome is they have this thing called ptosis or ptosis, which is a droopy eyelid. And usually a small pupil, and they don't sweat. It's a really weird condition. I just put that on there because it's one of those unique ones that you're like, wow, why does the eyelid droop with it? I have no answer for that. I don't know. It has something to do with the way that it involves the cranial nerves as well, but I don't understand it, so I'm not even going to pretend to understand it. I've never seen anyone with Horner's. I've seen all three of the Erb's, Klumpke's in total, but I've never seen a Horner's kid.
Mr. McKeever, I have a question that kind of digresses from this a bit. I didn't get the chance to ask Dr. Johnson last semester. So we learned that, there's 7 cervical vertebrae. Where does C8 come from?
Okay, so that's a great question. So, why do we have C8? So, your cervical nerve roots, where do they exit in relation to their vertebrae?
It has to do with the pairs, right?
Yes, right? Good. So, with your cervical nerve roots all exit above their corresponding vertebrae. So, if this is C4, they exit above my C4 vertebrae, right? Once I get under C7, they come out underneath. Good. So I get all the way down here to C7, right? So C7 is here. That's my C7 nerve root. The one that comes out below that is C8 nerve root because T1 comes out below T1. And if you ask me why, it's because a long time ago in a land far, far away, that's the way they decided to label them. But the main reason is because of the way that the cervical area is kind of organized.
Okay, so the cervical roots come out from the top, and then C7, C8 comes from the bottom, and then thereon after everything, the nerve roots come out of the bottom.
Yep. Yep, you got it. Does that make sense?
Yes, thank you for explaining.
Yeah. Because if you had that question, somebody else in here, I guarantee had it, but never wanted to ask it. I guarantee it. Somebody's sitting here going, yeah, Joe's like me. But does that make sense for all of you? Did you get it? See, look, they appreciate you, Amanda. Isn't that nice? Hooah. All right.
Yeah, thanks for making me not feel alone, guys.
All right, so let's talk about TOS, thoracic outlet syndrome. Your thoracic outlet is going to deal with your brachial plexus and all your blood vessels that go to your arm. And that's going to come up here. So here is my posterior scalene, right? So here's posterior scalene. Here is middle scalene. Here is anterior scalene. The middle and posterior are joined together. In between anterior and middle is a little bit of space here that forms a triangle. Can you guess what that's probably called? The thoracic outlet. Good, right? And the other term for it is the scalene triangle. Well, I wonder why that is. Well, it comes out of the scalenes, and it's a triangle, so it's a scalene triangle. So your brachial plexus comes out of there, your blood vessels come out of there, you get a, what do you call it, a vein that comes back through there. So all of that kind of comes through that little triangle, right? You can see it up here on this nice guy that's cut away. It's very common for at that scalene triangle to get entrapment. And entrapment means things squeeze down or compression. Main reason for it is tight scalenes. We all have tight scalenes. I can pretty much guarantee it. But when you have a true tight scalene, it's going to squish down on that scalene triangle. It can then also compress blood, so it'll cut off circulation. It can also compress nerves, or you get tinglies in your fingers, tinglies in your fingies. There are two main tests for this, to test for thoracic outlet syndrome. If you have the result, it is a positive result, meaning you probably have thoracic outlet syndrome. The first one you really cannot do on your own, unless you have like an Apple Watch or something like that. And it's called Adson's. With Adson's, you're going to find the patient's radial pulse. You're going to passively extend, abduct, and externally rotate their arm. As you do that, yep, it happens during lifting, yeah. Right, so as you extend back, externally rotate, the patient is going to take a deep breath, and they're going to hold it, and they're going to rotate the head towards the arm and extend the neck back. And what that's doing is that's squeezing that triangle closed. If the pulse goes away out of that radial pulse, and I don't like this picture because this is rotated away. It should be rotated towards. That's actually, I just realized the book is wrong. This is actually the Allen test, and you don't have to know that one. We're going to do the AdSense as the primary one you need to know. Because the 3 tests for thoracic outlet are the AdSense, the Allen, and the Bruise. So it's back here, rotate towards, and lift up, tighten that scaling triangle down. And if the blood pressure, not blood pressure, but if the pulse goes away, that means you have a positive AdSense, and that usually means you have a tight thoracic outlet. The other fun one we can do, and this one typically does provoke it. Well, this is to test for thoracic outlet syndrome, John. So this is actually okay to do with any patient. There's not really a contraindication. You can't hurt them for this, right? So this is where we're like, maybe, let's say I'm working with Truman, right? And Truman did his Olympic lifting, and he's been complaining that his hand keeps going to sleep on him. And I check his carpal tunnels. Carpal tunnel's good. I check all his ulnar. His ulnar's good. I'm like, I have no idea why his hand keeps going to sleep. And then I'm like, maybe it's his brachial plexus. So I do this test, the AdSense test, and he's like, oh boy, his hand may go numb out there, honestly. Or I go, oh, I lost my pulse. He's dead now. No, just kidding. Right? At that point, he's Schrodinger's patient. He's both dead and alive. I'm joking. That's not true. When the pulse goes away, that means that scaling triangle is super tight and it's squeezing down on his blood vessels. The other one we can do is called Bruise, and I always find this one's a little bit more kind of appropriate for a patient. So you bring both your arms out here about 90-90. Your fingers are up. You start out here, so you're going to hold this position for about 30 seconds. And what time is it? We can do this. I'm going to set my timer here. So we're all going to do this together. We're all going to look silly. It's more fun when we're together, but we're going to do it here. So everyone put your arms up here at 90-90. And what you're going to do for 3 minutes is open and close your hands for 3 full minutes. So I'm going to start the timer. Get your hands up there and begin. Just open and close those hands. If at any time your hands go numb, stop. Keep your head up nice and tall. Try to slump forward. Did I lose anybody yet? Has anyone stopped? Oh, you should have your hands up. You shouldn't be able to tell me. Probably getting tired now. Keep opening and closing. Keep it going. You've successfully completed 1 minute. Don't cheat like I was trying to do there. Keep those arms out at 90-90. If I lose anyone, type that you bailed out. Got a minute and a half. Starting to get tired. We're doing an endurance test here, folks. You can push through it. Come on. You can do it. I have faith in you. Okay, if your right finger's tingling, Oscar, that's when you stop. There's 2 minutes. We got 60 seconds to go, folks. 60 seconds. Keep it going. You can do it. Come on, be like, what's his name? Russell Simmons, not Russell Simmons. Russell Simmons is the rapper guy. Russell Crowe, no, that's the actor. Richard Simmons, there we go, that guy. The crazy gymnast guy. 30 seconds, come on, you can do this. Push through it, push through the pain. You got this. "20 seconds. Did they lose anybody else yet? Only lost Oscar so far. Or people are just pushing through it because they want to get the whole way through. Or no one's doing it. I can't see because I don't have my video on. 5, 4, 3, 2, 1, and stop. We did it. That was hard, right, Truman? You wouldn't think something simple like that was hard. All right, does anyone have tinglings in their hands? Okay, so Oscar said me. Did anyone else get any? I have a shoulder pump going on. Okay, it's got DOMs, okay. Okay, so Christina says she was saying, so that could mean that, like, if I'm gonna use Christina and I'm gonna use Oscar as my example here, it could mean they have tight scalenes, right? For me, I could feel my hand going to sleep out here, but I was not gonna give up. I was gonna make sure I push through it. So let me ask you something then. Why is it that your finger flexors didn't seem to get as tired as your delts did? Why do you think that is? Okay, I got more muscle mass. That's a theory, right? Everyone's delts kind of got a little tired out there, right? I assume. Like you get a little, yeah, a little bit of those abductors. Arms are heavy, good, right? The other thing is, think about it. Are your delts made for doing repetitive actions like that, where they hold that isometric for long periods of time? They're made for power, right? Yeah, they're made for power. They're made for lifting things, right? And the delts were shortened for a long period of time. They're not used to that kind of work. But think about all that you do with your hands all day long. Your fingers are made for endurance, right? All those finger flexors and extensors, they're made for endurance. They're designed specifically to last longer during the day. Just a little kind of side effect of that as well, as you think about that, like, oh, because we're going to talk in another lecture about white versus red muscles, you know, or what we call power versus endurance muscles. And it tends to be that your fingers, your hands muscles tend to be a little bit more endurance based, whereas a lot of your gross movers are more able to move stuff really quick and strong. So, yep, okay, somebody's coming in. Is that Brooke?
I just had a quick question with the just that triangle. So if it is tight, and then say you do test positive, if you did like one of those tests, since you said that it kind of cuts off the blood flow when you're feeling for the radial pulse, does that have to do with somebody who has like more of a bent over posture, and like they can get headaches more often because of that blood flow? It
absolutely could. So if I've got tight up here, that means I'm going to be like that. That means my neck is going to be also squished, which means the blood flow to the back of my head is also going to be decreased, which means I'm probably going to have more headaches. I'm going to have more cervical-based headaches, for sure. So it all ties together, 100%.
Okay, because my sister, she does like nails, and she has a headache like every single day, and I think it's because she bends over so much. Yeah.
Right. Yep.
I want to try it on her.
Oh, I bet her arms will go to sleep in about a minute. I can almost guarantee that. Or if nothing else, I bet you if you do AdSense, it'll probably vanish pretty quick.
Okay. I'll have to try both.
Yeah, try them, right? So here's the thing. So the problem is those scalenes get tight. That's the problem, right? It can be due to poor endurance, can be postural control, can be scapular control. All of that can happen. How are we going to fix that? How are we going to treat this? If we know the patient has thoracic outlet syndrome, what do we need to do to treat it? think logically. If I've got tight muscles, what am I going to do? Stretch them. Yeah. Right. This seems like a really complex problem with a really simple answer. Right now, let's say I have adhesions. That may be a little bit more complex, right? Or if I've got ossification or something like that, yeah, that's more complex. But for the most part, it's usually an anterior and a middle scalene tightness. So I can stretch them. What else could I do to those scalenes?
Strengthen.
Okay, strengthen them a little bit, right? Strengthen posterior scalene for sure. Right?
Massage.
So massage, there we go, right? Get in there and loosen those up with some good massage. And actually, if you come down that middle scalene, it usually feels really good. Okay, what other modalities could I use? Dry needling, okay, good. Anthony says I'm still not a fan of that, but okay.
Hot pack.
Hot pack, good. We can use heat, so we can use a hot pack. What other modality could create heat there for us?
Ultrasound.
Ultrasound, there you go, good. Right, so all of those are valid treatments for a patient that's got thoracic outlet syndrome, on top of the fact that we've got to correct the problem that's causing it. In the case I'm going to use Brooke as an example here for her sister, if her sister's sitting like this all day long doing nails, I've got to get her to sit upright and probably have a better chair, right? So that when she's doing nails, she has better posture. And I bet if she just has a little bit better posture, some of those headaches will go away, right? One of the other things that we can do, because I deal with this, I do gamer therapy, believe it or not. I've partnered with a company that helped design this bad boy. So this looks like your typical cervical travel pillow, doesn't it? Right? But it's specifically designed for gamers that when it wraps around, it pushes their head back into extension. So that I can come in here and I can clip it without getting my beard caught in it. Hopefully, I always get my beard caught in it. And I've used this quite a bit, so my magnet might be a little weak. And so what I can do is I can put this on when I'm gaming, and it keeps my head from being able to flex forward. Is that going to kind of keep my hands maybe from tingling if I've got thoracic outlet syndrome? What do you think?
Yes.
Yeah, right? Now, the downside to this, if I wear this all the time, I look goofy, right? I can't see a professional gamer wearing this to the event, but I wear this a lot when I'm doing, like, especially when I do because I'll do it coming up here in a few months. I do a 48-hour game stream where I stream for 48 hours to raise money for Children's Miracle Network. When you game for 48 hours straight, your hands go numb. There's just no way around it, right? I break out all the tools at that point. But correcting the neck posture is only one part of it. I also have to correct my physical posture, and that was what I was looking for, and I will eventually find them. I also have partnered with a company to do figure 8 braces. And what a figure 8 brace does is it pulls the shoulder back into retraction, so that it improves overall posture, right? So if the pillows kind of keep me here, the brace pulls me back. Now I've got that scalene triangle nice and open. I've got good blood flow going out to the hands, and I don't go numb. And it's funny, I work with some of the gamers, and I say, okay, we're going to put this pillow on you, and I want you to wear it for a week while you're gaming and let me know what happens. And all of a sudden, they're like, my fingers aren't going numb. Then I know I've got a scalene problem. Right? So if I've got a scaling problem, hold on here 1 second. Yeah, my headset's almost dead. If I've got a scaling problem, then I've got to stretch those scalenes too. And I've got to give them exercises to work with in order to loosen those scalenes up. But it's pretty neat that we can do simple things like that. Now, what happens if the people that I'm working with wear that pillow and that brace permanently? What's eventually going to happen to their muscles?
I think you end up relying on it more.
There, good, right? Your muscles are eventually going to atrophy. That's one of the reasons why I took this off for a little bit, because, eventually, even for a short period of time, those muscles are going to atrophy a bit. So I give this as a quick fix, because this would be one thing I can give them. I can prescribe them a pillow, say, I want you to wear this while you're gaming. Let me know if it improves your symptoms. If it doesn't, then I might have to chase a different breadcrumb. But if it does, I've got a breadcrumb I can follow. Okay, now put the figure 8 brace on. Oh my God, it feels so much better. yeah, my hands aren't tingling. And I know I've got a scalene problem. Right? And I'm not diagnosing at that point. I'm just chasing the rabbit down the hole. And then I report to my PT, hey, you know, I worked with Anthony, and when he wore the figure 8 brace, he got a lot of relief in his symptoms. And the PT's like, good, let's work on some goal setting for strengthening a posterior scalene, for stretching those anterior and middle scalenes, and for postural correction. So we'll do a lot of exercises where we're doing manual posture correction with them. Does that make sense, though? It's pretty cool that I can tie this to something that I do on a regular basis. So this is just kind of looking at the stuff that can do from it. A lot of times, the big one that I find in a lot of patients that causes thoracic outlet syndrome is this one right here. Their pillow. Their pillow or the way they sleep. Does anyone sleep like this? Is anyone going to admit to sleeping? Okay, so Anna's like, yeah. And Oscar says, yes. Ooh. So Oscar, right? If you sleep on your arm, think about that for a second. Look at my scalenes. I bet which hand went numb? I bet it's the arm that you sleep on more frequently. Oh, see, Stephanie, it just hit Stephanie. Ah, right. Now, is that everything? No, probably not. There's probably other things that cause it too. Oh, Anna, see, light bulbs going on for a few people, huh? Right? And that's, yeah, go ahead.
I had a doctor that called it like bar stool syndrome because
Yep.
I fall asleep on the bar like that. When people...
Yep. I'm trying to think of what that's called. I think it's called dead arm syndrome is the official term for it. But we also can do, there's a stretch that we're going to do for reverse fit called a sleeper stretch that we'll work on. But yeah, it's not necessarily bad, Stephanie, but it can lead to that whole area becoming more tight. So every morning I wake up, my arm's numb, right? So then we just have to work on training it, maybe getting you a different pillow. And there are all kinds of new pillows out there that are really cool that have where you can sleep on the pillow, but it's got an armhole that you slide your arm through in the pillow, and then your head is supported by the pillow, not by your neck. Yeah, Truman's seen them, right? And there are all kinds of devices like that, right? And there's also, I don't know, has any of you seen those new Cube pillows? They look like a gimmick, right? But they actually work. Because, again, if you look at the side of my head, it is not round like most pillows. It is square. It is an L. And we sleep on rounded pillows. They fit your neck hole, exactly. Right? So there are all kinds of stuff that we have for that. But again, if we just correct posture and don't strengthen and stretch, it's still not going to fix everything. Right? So it needs to be a holistic kind of approach. Just like we can't just do modalities, we have to do other things on top of it. So we're not completely done with this lecture. We got a little bit left to go. So let's stop there. We'll pick up with carpal tunnel syndrome on Thursday. All right, any questions? Was that kind of informative? Did you guys learn at least a little bit here?
I have a question.
Uh-huh.
Can you go back to slide 15 really quick, please?
What was at the top of it?
It was the classification of nerve injuries, the Sedons and the Sunderlands.
Sedons and Sunderlands, okay, yep.
The book is contradicting the slides. I just wanted to double check with you.
Let me check the book then. And how about I check the book and get back to you?
Okay.
Because I don't have the book home with me, so I have to grab it at the hospital tomorrow, or at the school tomorrow.
Okay.
So let me check the book. It's possible, and I may have to correct it. Maybe they changed things.
Page 393.
Yeah, I got that. Somebody corrected me on that earlier.
Okay.
It's connecting the dots. Yeah, right? Rain is fried. All right. Upgrade the movie. There we go. Thank you, Stephanie. That was the movie. All right. Well, if there's no other, I will get back to you on that, Truman. Let me look at that tomorrow when I'm at school. And other than that, have a good night, guys.